Yeah, I go to work every day. It's like there's nothing else to do, you know. Just
Yeah.
you can't travel.
Yeah,
How are
lucky
your
you,
events?
because ours, at some stage, they closed completely the OR setup. We were just doing virtual clinics. It was the peak where they have a high
Visit in our homes.
Anybody joining us? Are we having invaders, Pablo? Oh, here, yeah, Fred. Fred, are you with? Do you hear us, Fred?
It's muted.
You have to unmute yourself.
I'm trying to do so.
Can you hear me now?
Yeah.
Yes. How are you? Good to see you.
Not too bad. Terrible. I have surgery this morning, but you know, I tried to change, but I could not. So interesting. I'm doing a endoscopic meningioma with ENT. So you know, they're starting off. How are you? You look like you're wearing. Everybody's developing a beard these days.
This is the relaxed appearance during COVID time. So
Also, you can cover it.
It's very funny, Imad, because you know I'm exactly like you. So in the last 5 days, I had you know like a lot of things. Gina, you know Gina,
yes.
you must shave. You cannot go on the video. Look like a homeless man. You, so she forced me to shave last night for this video. Otherwise,
it looks like a fresh shave, yeah.
Exactly. I'm just like you yesterday, you know, because the funny thing is here, I don't know about you, but in the hospital, we have to wear a mask. Do you wear a mask?
Yeah.
Of course.
UK, we have to as well.
We are doing tests. At some stage, we were doing every day.
Oh, wow.
And then became
like
once
this.
a week.
Right. So we are like this, so nobody can see if you got a beard or you're unshaven.
Yeah, exactly. That's what I said, but I forget that I'm going to see you without the mask.
So, Imad, I guess I know you have a very, you know, schedule, it's all thing. I guess there's no way I could go a little bit earlier just because of the OR.
Well, let me see. We might
see what you can do. If it's possible, it's possible. If it's not possible.
What I can do, perhaps, will get you after Andre the House.
Okay.
So you will be one presentation earlier.
Okay, yes, whatever you can would be helpful for me just because of the stupid OR that I have to do. Yeah. So, okay, I'll do it. So are you trying to make sure that everything's in? So should I try my presentation?
Check share your presentation so we can see if we have it.
I'm going to minimize this.
Matt, sorry, I missed yesterday about the Stefan Florian presentation, and I mailed him, but I don't know what's the plan. Are you planning to put it today?
Stefan Florian, he presented.
Finally.
Yesterday.
Yeah, he did. Yeah, he did.
Immediately.
So okay, because I was mailing him, and okay, so he fixed it.
Okay, so now I will minimize and bring up the Zoom. So how do I get back now to share screen?
It should be at the bottom of your screen, like a green button saying share screen.
Yeah, I don't see that now. Let me just see.
Are you watching us? So you have a gallery view with all of us?
I can only see you.
Okay, so click in the upper right corner. You will see something which has gallery view or a speaker view.
Hi, Vladimir.
Hi.
Click on gallery view.
Vladimir.
Hello.
There you go.
Zoom, let's see.
So now you can see all the faces, is it?
No, I still cannot see that. Let me just see. This is Zoom, not here, here, Lacey here. Here.
Perhaps minimize your presentation and you will be back on that screen. If you minimize your presentation.
I can see you now, Imad, but I can't see everybody.
So can you see Matt or me now in a small screen or a big screen?
I see you in a very small screen. I see you now
Okay,
that you're talking.
So go with the mouse on that screen, you will see an arrow pointing upwards. You click on the arrow to maximize the zoom.
There's, oh, the Zoom. Stop video. No, I see that arrow. Exit, minimize. Okay, there we are.
And now share screen in the bottom.
Now we get up here, and now I can share screen. And there's my presentation. And here's my first.
Yeah, we see your presentation.
See it now?
Yeah.
Yes.
Excellent. Okay. So now I will stop sharing, I guess, right?
Yeah, you stop sharing. Yeah. You just click on.
Okay.
Wonderful.
Looks good.
Vladimir, Igor, hello.
Hello.
Oh.
How are you today?
Hi, Vladimir.
Bill.
Hi, Vlad.
Hi,
How are
Fred.
you?
Hi, all. Ek. Hello.
Where is the egg?
Hanging in there.
Ek is the second row from the top.
Hi.
And there's Bill. How are you, Bill?
Hi, Fred. How are you?
Oh, hanging in there. That's all we can do these days. Yeah.
Where is Roy again? Roy is in the OR or is he doing an
He apologized to be part of the moderator. I don't know where he is. He must be busy.
Uh-huh.
But
That was the
that's
same
why,
yesterday.
Yeah.
The empty
Yesterday he
room.
was attending and then disappeared. I don't know.
Right.
Today we have.
Roy's team is there. I think Roy's got his colleagues attending.
Oh, someone's there.
Yeah.
The famous boardroom.
Right. Imad, how many people did we have yesterday?
Well, Pablo should tell us. I don't know. I didn't
Pablo?
check.
I think around 200 and 300.
Wow. Excellent. Yeah, these Zoom meetings are incredible. I say that this virus has caused many bad things, patients, whatever, but there's some positive things that have come out of this. And one of them is this virtual teaching, which is
we are doing the same with the university. Yeah.
Exactly. Medical students. I'm the director of undergraduate medical education, and we're doing virtual educational study, and it works to a degree.
The worst part of it is the simulation of clinical practice. This is the most difficult part.
Yeah.
Without seeing patient and attending patients, I don't know how they will function properly in the future, but they needed to compensate it later.
That's true, very true. It's because sometimes now I do my virtual consultation virtually. A new patient needs an operation, does everything. The first time I see her is before I go, she's going into the operating room. They see me there because we don't see it. And so it's very difficult for the patient. I cannot imagine, undergoing a brain operation and never seeing, maybe with video, but never really contacting your surgeon until they're going into the room. It's amazing. It's amazing.
Is Dr. Cassidy with us?
Not yet. I can't see him.
No.
All right.
Not yet.
Okay, I think I will give some introduction before we start sharp at 12 Greenwich Mean Time. I'd like to welcome all the faculties and the special guest we have, Fred Gentili from Toronto and Bill Caldwell coming from Salt Lake, US. And of course, the members of the committee, I have all of them with us. And the moderator of the session, which will be covering pituitary and craniopharyngioma, will be Pablo Gonzalez from Alicante and Ramesh Nair from England. I'll be joining them as well. And the presentation, there are 8 presentations. We'd like to be possibly sharp on time because some of you will go to the OR. 20 minutes for the presentation and 5 minutes for question and discussions and answers. This will be the courtesy of the moderator to be selecting. And some of the questions can be answered later on by the faculties on the chat. And we have distinguished people from the community that we know attending this webinar. I just have a message from Dr. Subeh, and I don't know Dr. Armando Paso always attending this one. I'm sure they have some input. The presentation, myself, I will be starting with the introduction and talking about pitfalls and challenges in pituitary. Then we have large supracellular extension of pituitary tumor will be handled by Kasadi Kalango from Zimbabwe. Giant adenoma will be handled by William Colwell. And then we'll move to Dr. Andre Gutenhaus from Holland. We'll talk about approach to cell and surrounding and covering the anatomy as well. Then we will advance the presentation of Fed Gentili on craniopharyngioma, how I do it, as he will be going to the OR. And then we put the Indonesian endoscopic surgery in children for Dr. Chandrasekhar Adubo Jari from India. And then Henry Schroeder will talk about the outcome of the pituitary gland, very interesting subject, section or no section, he will talk about it. And then last but not least, Eckhart Kasper will, from McMaster, he will talk about selection of approach for the craniopharyngioma. Without further ado, I'll ask Pablo to commence the session. And I'll share my screen. Am I on time or?
Yes, we still have 2 minutes to go.
Okay, so I check my screen myself, make sure are you allowing me to share my screen?
You should be able to do it. It's allowed. Yeah.
Do you see it?
We see the PowerPoint. Yeah, we see it now. Okay, so it's 1 minute. So welcome everybody to this second session we are having today. And we're gonna have amazing leaders in the field of the cellular region, surgical treatment, and we will mainly focus on craniopharyngiomas and pituitary lesions. And I'm very honored and pleased to introduce our first speaker, who is Dr. Imad Kanan. He's professor and the chairman emeritus of the Al Faisal University Hospital, Department of Neurosurgery in Riyadh, Saudi Arabia. And he's the chairman of this committee of the World Federation of Neurosurgical Societies Neuroanatomy Committee. And as you all know, he's highly involved in worldwide neurosurgical education. And let me tell you, please, that if you are attending to this webinar, it's thanks to him because he did a huge effort in the last months during this COVID era to create this program, this online program. So he's opening today's session talking about surgery and challenges in management of pituitary tumors. So all yours, Professor.
Okay. I'd like to welcome the attendees from all over the world, and I'm going to talk about the challenges. Pituitary adenoma is not a static disease. This is the same patient. 3 years later, he has this explosion of his microadenoma as he refused surgery. So you should handle these cases very seriously. The pituitary neurosurgical career is different from the handling malignant tumor. We are always trying to attempt to cure, attempt to palliate, attempt to comfort. And there are different steps that we can perform this by the selective resection, preservation of the gland, and try to maximize the resection. Option of treatment is not only surgery, there is a potential medical treatment like in polactinoma and radiation therapy in some of the cases that we fail to treat, and some of them, they are amenable for the stereotactic radiotherapy. So the most challenges we have in pituitary surgery is localization in microadenoma. Microadenoma is not always seen on images, and localization becomes a vital part of the management of these patients. Giant pituitary adenoma, it will be covered nicely by the two consecutive speakers. To achieve a total resection, this is the challenge. Management of recurrence even sometimes much difficult. And we have, although it's not very common, but atypical and malignant pituitary tumor, to control them, they can be very tedious. So the anticipation of pitfalls, this is very important step to protect yourself from complication. You might have radiological pitfalls, endocrinological pitfalls, and surgical pitfalls. And I'll give a few examples on this one. But first, to avoid these, you have to understand the anatomy of the sphenoid sinus. Is not one chamber or two chambers. Sometimes the trabeculation is tremendous. You will end, if you don't understand your anatomy, in the cavernous sinus, and you won't find your lesion. And vascular anatomy is important, especially when you're handling an invasion of the medial wall of the cavernous sinus and the carotid artery, or the supracellular component that it goes through the dura, and you need to handle the superior hypophyseal artery and be careful not to cause ischemia on the optic chiasm. Tumor configuration and extension is very important, and this is the grading system from Dr. Nosp. Here are a few examples of some of the imaging conundrum that tumors sometimes they are very small to be seen, like this one is a microadenoma. You don't see it. If you go in the wrong chamber of the sinus, as you see here, you end in the cavernous sinus and you won't find your lesion. So study this one, and to go, you have, this is the microadenoma, you can appreciate. There are sometimes tumors, they are not seen at all on the images, and it's an infacellular tumor, like this one here. See, there is a small infacellular tumor. This is the microadenoma we find. We have completely pan-infacellular tumor that has only a small connection here. The rest was an adenoma, non-functional, extended a different way, not always supracellular, extremely rare here, but it went down. This case, we thought this is a chordoma, but when we checked the hormonal profile for the pituitary, his prolactin level was 2,500. So it's an invasive prolactinoma. The treatment was just bromocriptine and radiation therapy because it's an invasive by definition. This case referred to us with this lesion for transcranial surgery. When we checked the hormonal profile, her thyroxine level was down to the floor, and then we have to replace her before we start planning the surgery. In 4 to 5 weeks' time, we repeated the study, and that's what we do always, and it shows the resolution of that lesion. It's a secondary hyperplasia of the pituitary gland for hypothyroidism. So these are the pitfalls you have to be careful with. Microadenoma, the best study to do the images immediately post-contrast injection. That's what we teach our radiologists, because pituitary is one of the P's that has no B's. And I always teach this to my residents. Pituitary, pineal, plexus, and area posterior, these are the 4 areas they don't have blood-brain barrier. So contrast will go first to the pituitary, normal pituitary, and save the contrast to the adenoma. If you wait long, that adenoma will, by diffusion, will be enhancing. So this is very important when you go for planned surgery. In these cases where you have completely negative images, like in this one was reported as partially empty cellular, and with the stalk deviated to the other side, and the cisterna is herniating down, the only study was positive for us was the PET scan. And we have performed some studies on this one in 25 patients where we have a negative MRI. We did have a positive PET scan. There is a similar study done at Malaga, where Dr. Regis' daughter, and she confirmed this one as well. So inferior petrosal sinus sampling is not 100% study, and you need to have dedicated, good intervention radiologists that he put the catheter in the inferior petrosal sinus. Yet even he put it there there might be contamination from the contralateral side that you have to judge it very well. A gradient from right to left and from central to peripheral is very essential to make your plans. Nowadays, we depend more ourselves on the PET scan. In the surgical aspect, all these contributors to the transfemoral surgery, from Schloffer, the first, and ending by Julius Hardy, who introduced the microscope to the surgery. And the most important invention he did, he coined the microadenoma. That's very important. But I adapted eventually. H. Griffith from England, Bristol, he introduced a minor technical note in the Journal of Neurosurgery in 1987, which is the direct approach. The direct approach that saved us a lot of time and complication of the intranasal cavity, whether it's a sublabial or transeptal approach. Nowadays, most of the pituitary, I don't want to be like the election in the Middle Eastern country 100%, but I say in 80 to 90% transfemoral surgery is the approach for pituitary, whatever in general the size. And I'll give some indication for craniotomy later on. And the endoscopy was introduced by many from the 1997, the Pittsburgh group. And you notice all this group I'm mentioning, whether it's the Pittsburgh, NAC, the Italian, the Austrian, and the Brazilian, they all worked hand in hand with the skull-based ENT surgeon. This is where they could accommodate and share the knowledge together. And that's why the approach, most of these people, they do joint venture, they like to go through the ostium of the sphenoid. These are the contribution by endoscopy. I have to say, Joe was the very first one who has popularized the endoscopic pituitary surgery, but there were some successful resection by Jankowski in 1992 as well, and of course the group from Italy and Stum from Brazil. We are handling that tumor that sit on this sphinx, and we usually, when we start, nowadays I'd like to make the flap, the Haddad flap, because I need to dissect the mucosa from the face of the sinus and from the posterior septum. So I'll make the flap, have it ready. If we get a leak, we can always use it. And then this is the flap usually, and it's a vascularized flap. I like it from the septum rather than from the lateral wall. And we follow the nostril down to the sphenoid face. The anterior wall of the sphenoid sinus, I always put that picture, looks like a face. And we want to do the facelift, not by plastic surgeon, by going either through the eyes, which are the ostium. Most of neurosurgeons trained with the microsurgery and the direct approach, we'd like the midline, and I'd like to displace the septum to the other side and expose the sphenoid crest. This is my actual midline. And then I drill between the two ostium and take a stamp of bone as a face lift. Now, the issue, endoscopy or no endoscopy for that phase of the procedure, which I call it the nasal phase, I myself, being trained more in the microsurgery, I still like to put my short speculum to do the flap and then take it out and go do the face lifting down. And with the technique, we have, after all these approaches, they go to wrong, okay? And this is the endoscopic approach. I don't like to mobilize the turbinate unless it's needed if they are a suprasellar component or you are doing something more than pituitary. And for the ENT, this is nothing for them. It's not a maximally invasive. For me, it's not a minimally invasive as well. The nasal integrity still remains an important component of a human being. And you see the superior turbinate hide the ostium behind it. This is where the starting point for most endoscopic, purely endoscopic surgeon, I'd like to start from the midline laterally. and important to understand the vascularity and each impression if you are going to do the extended approach, whether it's an optic nerve, the recess, and the carotid bulge. Navigation became an essential tool, especially when it comes with the recurrent disease. This is with the recurrence, it's very difficult with the fibrosis and changing the anatomy. Fluoroscopy, not anymore in my practice. Endoscopy give you that view, the near vision, this is the panoramic view, the visual access to blind angle and completeness of the tumor resection. And I'll give some statistics later on. This is the approach I'll do, what I have modified. I'll put the speculum, the short one, I'll make an exposure to the, and displace the septum. Then I made an incision through the left nostril and I advanced the endoscope there. Once I reach this stage, I'll take the speculum. That stage, it take me only 5 minutes. And then I'll drill under the endoscope. And then once you resect the tumor, you see they have herniated diaphragm ocelli. And this is the value you can look in the corner. This is the left medial wall of the carotid, the cavernous sinus, and even you see some fenestration here. This is the left carotid. So exploration of the gland where you don't have visible adenoma is tough. And because you have a normal cellular size, it's more bleeding, and abnormal tissue is sometimes difficult to recognize, and you need to do multiple section as needed. The new indication for the extended approach, all these indications were in the past for craniotomy. Now they are shifted to be, with the help of the endoscope, to be part of the transfemoral surgery. And I staged the procedure, as I said, nasal, sinus, cellular, and supraparacella regions. And I like when I resect the giant one, I'll start from the lower and lateral and leave the upper part to the end. This is where the important structure you have, the chiasm, the A1, the ventricles. I keep it to the end, so this will descend slowly down with the hope in one stage or second stage. And this is one of the cases before surgery. Sometimes studying the radiology is very important because you see here, this is some apoplexy on the top of this tumor. So you understand when you reach that one, you understand that you are already on the uppermost part of the tumor. And of course, the endoscopy here, in that case, 30 degree is very essential to help you in resecting this tumor. And this is a post-resection. You see the empty supracellular cisterna. It's another case. This one went into 2-stage surgery, and this is after the second stage surgery. We are privileged to have this one. We have a big talk about it yesterday, whether it's worth the money or not. I found it's worth, especially in these cases where you have a giant tumor and endoscopy, you are not 100% that you have removed it completely, although the endoscope gives you a direct view. But the MRI is the final version, and sometimes we do it, sometimes I do it immediately at the end to save a patient another visit to the MRI. So everything done, so the day after, if he's doing fine, he can leave home rather than wait for an MRI. This is some of the results published by Comatua in 2012, comparing the endoscopy versus microsurgery and craniotomy. The comparison with craniotomy, I think, has no value because nobody going to compare this one. We know the result and the minimal invasive of endoscopy. But endoscopy can coherent that the extent of the resection much better from both, much better than the microsurgery, especially in the macro adenoma giant tumor. And I have to say the outcome for the pituitary function better. The only concern was the CSF leak. Now with the vascularized flap, this one went down tremendously well, and people there don't have that major concern about it when they are dealing with pituitary adenoma. This is for the outcome of microsurgery versus endoscopy, and you see DI is worse in microsurgery because the endoscopy, you can visualize the stalk very well. And in microadenoma, it has value, not like what I thought in the past, because you can see behind the stalk, you can see medial wall of the cavernous sinus, and you can see the infradiaphragmatic component, which sometimes you have corner blind for you under microscope. The preservation of the pituitary function is very essential, and selection resection, and we moved from digging inside the pituitary gland, the tumor, to go around the pituitary tumor. I take the ball dissector and I dissect the tumor from outside the periphery as an extracapsular versus intracapsular resection. And this is a fantastic technique because it gives you a more thorough resection of that one. Transposition of the gland, I leave it to Henry to talk about, but I know in some of the publication for Amica Sam, there was issues of the dysfunction of the pituitary due to ischemia. A few pitfalls, tumor entrapment, that was an issue in the past with the help of endoscopy. Of course, when you take that tumor out, we used to put the patty on the herniated diaphragm, push it with the dissector up to retrieve any tumor hidden behind or laterally. Nowadays, you do the same and you put the endoscope, you can visualize any residual entrapped tumor to take it and make a thorough resection. And you can use a different technique. These are the old technique, but again, endoscopy was an essential. Bleeding can be a nightmare. From intercavernous sinus, there are several bipolar now available. You can coagulate nicely, especially when you are do the annular sinus, we want to go in the extended approach. Cavernous sinus oozing or bleeding, and vascular injury of the carotid, because some they go very aggressive to the medial wall, which I don't do. I don't have the expertise with this endoscopy to go to the medial cavernous sinus inside the cavernous sinus because I'm still concerned about the pitfalls. But there are people doing it with good results. But recommendation, use the Doppler probe, neuronavigation, and of course, hemostatic material. There are plenty of them. And always warn, if you are going to go that aggressive, warn your intervention radiologist to be available. Chiasmal syndrome, I've seen one case in my practice. And I don't know what now in retrospect whether it was a real chiasmal syndrome because of the chiasmal herniation or not. But in general, the pathophysiology is ischemic in nature. Are there indications for the craniotomy? Yes. There are some multilobular configuration of the tumor and vessel encasement like this one. I won't be daring to go for transcranial with confidence. So I still like to go craniotomy, and I'm sure my colleague, Dr. Kasadi, will revere and Bill will talk about it. Apoplexy, if it's a large tumor, I will go immediately for surgery to decompress. Our endocrinologists, they always want me to wait, and I don't wait because if somebody is losing vision, this is a valuable time interval that I will go after. If he has no visual problem, I would wait because they will shrink. And a small tumor, I will wait. But a tumor like this, I will go after. And this patient came from no vision. In 24 hours, he received 90% of his vision. Is there a place for other treatment? Radiation therapy, of course, can be an alternative. But in Cushing disease, if you have a recurrence, the first things you go re-explore. They are still the best treatment for microadenoma of pituitary, and this I quoted from Sir Ed Lowe's, and I applied the same practice. And sometimes we do, if we don't find the tumor, we do a semi-section of the gland on the side, or we have lateralization. External radiation therapy and the stereotactic form and bilateral adenectomy, we have not done it for many, many years because of the issue of Wilson, but if you failed everything and after radiation, you give it not before that, otherwise you get the Wilson syndrome. These are the factors you have to consider with radiation. Of course, panhypopituitarism, visual deterioration, it's reported in 2% by Steiner application, radionecrosis, and transforming of a pituitary adenoma to a carcinoma. We have 2 cases in our practice with a bone metastasis. The outcome of pituitary surgery is influenced by the size, location, but most important, surgical technique and experience. You have to be a good endocrinologist as a surgeon, and you have to work hand in hand with the pituitary. This is the association. You have to have an invasive pituitary internist and a minimally invasive skull-based surgeon. Remember, most of our practice is not only based on science. A human being is born with affinity to novelty. We like something new. This is novel. We like innovation. and we like to overcome challenge. We don't like the easy case. We like to go for the exam. So consider this one in your judgment when you adapt the practice. Thank you very much for listening.
Thank you
Am I
so
on
much.
time?
Yeah, it was perfect. Perfect. Thank you so much, Imad. 20 minutes sharp. So thank you for this perfect summary about pituitary surgery. And we do have some questions in the chat that, if you don't mind, I'd like to transfer to you. The first one was done by Dr. Takashi Kon, but maybe he can directly ask questions.
Yeah.
Yes, I want to ask about, we sometimes for the giant tumor, we use both endoscope. If, as for your experience, how did you do the transcranial combined surgery, transcranial and endoscopic?
You mean from below, from above?
Below, from above, yes, both.
Well, I haven't done the combined. I usually attempt to maximize the resection per endoscope. And you see the two cases, they went nicely. I have one event where I have apoplexy of the residual tumor up. This is the time before the endoscopy and before the time of intraoperative MRI, where we have to, the patient crashed 30 minutes after the surgery, did not wake up. When we did the studies, he has a hemorrhage of the upper part with acute hydrocephalus. The acute hydrocephalus was that caused the trouble for this patient. He herniated because of the acute hydrocephalus. So we put with the endoscope from top, and we drained the ventricle, put an EVD, and we took whatever residual hematoma from top through the ventricle. But he did not do very well. He woke up, but he did not do very well with hypothalamic disturbance due to the herniation.
Okay, thank you. Thank you.
Thank you. So we have one more question from Mohamed El Maghrabi from Egypt, and he's asking you which are contraindications of endoscopic endonasal approach in surgically indicated pituitary adenomas rather than sinus infection that could make the decision to go for a transcranial approach.
If there is a sinus, you see most of these adenomas, this is not an emergency unless you have an apoplexy. So I will treat the sinusitis, and I don't want to subject him because of that to a craniotomy. I still treat the sinusitis and I'll go for the proper transcranial surgery. Now, indication, a kissing carotid artery has been always a potential risk, but now with the extended approach, you might overcome this one going higher up. But this is one of the potential indication, okay? Conchi sinus is not contraindication. We see it in pediatric. People doing the pituitary in Cushing in pediatric, they know that. The sinus is not well pneumatized. Pneumatization becomes full in the age between 7 and 9. So before that age, you don't have a sinus to work on, but by drilling the upper clivus, the conchi part, you initiate an infracellular area as a cavity, and you can still go with the endoscopy.
Okay, so can I ask the rest of the panel if they have any concern? Ibrahim, please.
Yes. Thank you, Ahmad, for a very interesting presentation. You mentioned about the apoplexy presenting with visual loss. I agree with you totally that one should not wait on these cases. You should go in completely. I just want to know the opinion of the other panelists about this. How much time would they wait on apoplexy with visual symptoms?
Oh, so I guess the issue is when you say visual compromise is the degree. And, you know, there's a lot of controversy on this. You know, there's now the PASTOR study, which I'm involved in. You know, it's a worldwide study to sort out exactly when. So the degree, and I agree, everybody would agree with Imad, significant visual disturbance, visual field defect, operation, no question about it. The question is, you have somebody who comes in and, you know, their vision is to 20/30, they're fine. That's where the issue is, should you operate on this patient? Wait. And on those one, it's a judgment call. You have to look at the patient, you have to whatever, and sometimes I will wait on that patient. And then, and then within, if there's any evidence, we watch them closely. Of course, any evidence of deterioration, immediately you can do it. But so it's not 100%, vision, because we know what is the vision. But any significant visual disturbance, absolutely, I think operation is indicated.
And just also remark, which is very important in apoplexy, is that these people they don't only present with visual disturbance. They have severe headaches, they are vomiting, they are dehydrated, they have an acute hyperpituitarism. And if it is possible, we would like to have the endocrinologist first take care of them and have good hormonal replacement, bring him in a better condition. And of course, one of my last cases was indeed a young man who came in blind since 2 hours. I mean, then you don't have any other possibility than immediate surgery. But to be honest, these are very rare. I was in the writing committee for the current guidelines on apoplexy. And indeed, it is not always a surgical emergency. Not always. So don't jump into it immediately. Look at the patient, as Fred was saying, if they are still doing fine, they are doing well, and their vision is still in an acceptable level. Also, let's say double vision is not necessarily an indication to go for surgery. But I see that Kiki is waving already to also give some comments.
I think he's speaking with someone else, I think. But let me welcome Keki, Victor, Atul, Ibrahim, Andre, Chandrasekhar, Avida, and Aib, who just joined us during Imad's talk. And there is one more question that, if you don't mind, Imad, you could answer. Sure. Jorge Salazar from Ecuador from the chat, because we are running to the next. And during your presentation, I got a message from Kasadi that he's just arriving at home in Brussels. He had to fly, so he will be 20 minutes delayed. So if you don't mind, I don't know if Bill is ready.
I think Bill will give, and then we'll give the chance for Fred. He has to leave to the OR. So we'll advance him an additional lecture.
Thank you.
So do you want to introduce Bill Caldwell, Imad?
They are both
yeah, both Caldwell is known to international and in his country and internationally. He has a marvelous input on international education. I've seen him in most of the international meetings and seminars and hands-on courses. It's not only in US, he has been to many Asian countries. And actually we became friends through these intervention and endeavors. He has a great experience. He was with the Professor of Fukushima for a couple of years, and he was originally from Canada, from Montreal, trained there and moved to the state, to California, and he spent most of his time there and eventually chaired the department in Salt Lake. And I know some of my faculties, junior faculty, they were adamant to go to his fellowship training because he is leading one of the highest level educational activities in the US. And I'm very happy. He is the president of the World Academy of Neurosurgery. He has many leadership positions. And I think the venue is not to, otherwise I would spend his CV is long, but I'm looking for his presentation on the subject. Welcome, Bill.
Imad, thank you very much for that introduction. And it's so good to see so many of my friends this morning. It's early here in Utah. I know it's in the evening for most of you. But I'd like to talk about a very important topic in skull-base surgery and obviously in pituitary surgery. And that's the management of giant adenomas. This is where I live. It's a beautiful venue. And, you know, we're over 100 years of pituitary surgery. It was ironic that Cushing was initially very, very motivated to do the transfemoral approach. He did over 200 cases and published them, but then dropped it in his career because he felt that he didn't have adequate lighting and visualization of the optic apparatus, which he was trying to decompress. And there was really three men that really held the torch for the transphenodal approach: Norman Dott in Edinburgh, Gerard Guillot in Paris, and Jules Hardy in Montreal. And ironically, I was a medical student at McGill, and Jules was my mentor in medical school. And he was in the peak of his career at that time. And even recently, we just wrote a biography on Guillot, and the remarkable contributions that Gerard made. And Jules is still very, very active and very intellectually active, and he's in his late 80s now, but his mind is very, very sharp. So this was a brilliant man who actually did the first endoscopic approach to the pituitary tumor back in the 60s. And we have a video of that. And here's Guillot and Hardy, probably 20 years ago. But let's talk about giant adenomas. Jefferson first coined the term, but I'll use it in tumors larger than 4 centimeters. And as you all know, there's difficult giant adenomas and there's easy giant adenomas because it depends on the growth pattern of the tumor. But this is how we'll define it for this talk. Pituitary tumors are common. Giant adenomas are a minority of the pituitary tumors. And the presenting symptoms here are visual disturbance, endocrine dysfunction, and compression syndromes. And we treat all prolactin-producing tumors, irrespective of size, with medical therapy and reserve surgery for those that don't tolerate the medicine or don't get shrinkage of the tumor with the medicine. So this, I want to credit Tool, who's on the call. So, and I agree with this. This is really a finesse delivery of the tumor. And you have these very large tumors and you're able to remove them through the transphenodal approach because the tumor in most cases is soft or cystic. And it's remarkable to me how actually resistant and resilient the pituitary gland is. You can have a tumor such as this with just the, as you know, the pituitary is sitting as a cap at the top of the tumor and compressed by the tumor, and you end up with a very atrophic looking gland at the end, but you can still have pituitary function. So it's a remarkably resistant structure. So how do we get these big tumors to drop? Let me show you a few of the tricks that I use. This is actually just being published in a large series right now. But originally Hardy and Guillot published this as the opening. This is not the opening that I use. I use an X, and this allows you then to go up to the corners and get to the walls better. And this is the key to getting these tumors to drop. So, or you can remove the dura completely in a big patch fashion. So there's a few other tricks that we'll use. So I remove the floor of the tumor first and get a good view of the floor, and then start to work on the walls. And the way you get a roof to drop is you remove the floor and the walls. And if you remove the walls and go up the gutters, you won't leave tumor in the creases and the folds of the arachnoid, which is the challenge. And then I work on the very back and the interface between the diaphragm and the arachnoid and the tumor, and try to tease the arachnoid down and just remove the tumor on that face. If you get the arachnoid to fold in from the back and then to the front, again, you'll have less opportunity to leave tumor up in the folds of the arachnoid. I also try to preserve the arachnoid. So I try to avoid a CSF leak, because remember that the CSF pressure is your friend. It's your surgical assistant. It enables you to use intracranial pressure through Valsalva or bilateral jugular venous compression to help bring the tumor down. So we'll use this very strategic method to try and remove the tumor and to get it to drop. And obviously it depends on how big it is and whether there's special compartmentalization and whether it's gone through the arachnoid up in the cranial cavity. I want to just credit Ed Laws, because he's the one that taught me the bilateral jugular venous occlusion. It's the big gun. You just, you can do it through the drape, and it's very effective. It's like an Uber Valsalva maneuver. So your options are a single transsphenoidal approach or a single transcranial approach, or actually combining the two. I've done them combined. I don't like to do them combined in general because I always think that I'm contaminating a perfectly clean approach from the top with a clean contaminated approach from below. But you can see the advantages and disadvantages of each of those. The combined approach does actually ensure that you'll get decompression of the optic apparatus at the initial surgery, and I'll talk about the importance of that. So if you look at the mortality rates, they're very high in the previous era of these giant adenomas, and they remain high relatively to other surgeries. And these are treacherous tumors, and I think that it's been alluded to already in the discussion, but you can see the mortality in all of these series. And even a decade ago, we had 4.4% mortality. So this study looked at the combined literature and of giant adenomas, but they had 4.4% mortality. And does the endoscope add and improve the resection of these tumors? Well, it does, and that's intuitive, and you'd expect that. And we use endoscopy for all these giant tumors because they're all in places where it's difficult to see through a standard transsphenoidal approach. But if you add the endoscope, it enhances removal. No matter which approach you're using, whether you're coming transnasal, transsphenoidal, we also use it transcranially. And so we've actually looked at the last, actually 105 patients now, but this will describe 100 patients. I wanted to choose a contemporary series that was within the endoscopic era so that we'd have a good series with good follow-up with our own results. And we looked over the past, we had 741 patients over the past 15 years or so that we had decent follow-up on. And we analyzed 100 of which ones we had imaging on for pre and post-op. And you can see the baseline characteristics of the patients. Visual acuity deficit and field deficit is the predominant problem that they have. This is what I want to point out, is that all of these giant adenomas, they have a very high incidence of cavernous sinus invasion, which limits the resection. And this is why the gross total resection rate is so low. And this is just to remind you of the NAC classification. So certainly grade 3 and 4, significant cavernous sinus invasion. The lower grades, sometimes I'm unsure because the medial cavernous wall can pantaloon and be indented by the tumor without invasion. And you'll find that out during surgery when you take a look at the medial cavernous wall. But a lot of these tumors have very extensive invasion of the cavernous sinus. So you can see the approaches that we've used. So we'll do a combined approach, but we'll often stage them, usually in a very short period of time, for the reasons that I mentioned. And the complications are listed here. We did have one death in the series, and I'll tell you about that. So the mortality rate is dropped, but it's still not zero, and they're treacherous, and I'll tell you why. So let me show you a few illustrative cases. This just demonstrates the extent of apoplexy that you can see. And I think people don't always remember that apoplexy is a continuum from infarction of the gland to hemorrhage of the gland and the tumor. And this is in a case where he came in, and you can see that on the enhanced scan, there's absolutely no enhancement on this in this tumor. And so it was sent down to me as a cyst, but in fact, he had acute headache and bilateral 6 nerve palsies. And so we operated on him. And this was a giant apoplectic infarcted pituitary tumor with very, very little hemorrhage seen. So just remember that infarction can produce an apoplexy syndrome independent of hemorrhage, and you may have these extremes where you don't see the hemorrhage so easily. And so here's his post-op scan, and his 6 nerve palsies improved over approximately a month to 2 months. So the transcranial approach is used, and I would, Imad talked about this, but if there's constriction of the diaphragm, paracellular extension, kissing carotids, as he mentioned, and I will add cranial neuropathy from cavernous sinus invasion. So what would you do with this patient? And this just shows the evolution of how I've thought about these tumors over the year. This patient came to me probably 15 or 20 years ago. She had a 100-pound weight gain and cognitive decline. And she's got this very large tumor. So the residents placed a ventricular drain in her, and she's got this giant adenoma. It's somewhat compartmentalized. There's a bit of a snowman effect here. So could you get this to drop down? Well, I did. I came endoscopically and we tried everything. This was a non-functional tumor. And I used every instrument that I had, and you can see what we achieved. So we did okay. We maybe got half, 2/3 of the tumor, but I just couldn't get the upper part to drop. Now that's fine if you're lucky. And so we came in transcranially the next day and removed the rest transcortically. But let me show you this patient. He's a 42-year-old man, cognitive decline and headache. The tumor was very soft, and I thought I got a lot of it out. I came in transnasally, and he ended up with bad apoplexy the night after surgery and had a herniation event, just like Imad talked about. So this is the feared complication of these giant tumors. The reported incidence ranges from 5 to 12.9%. So I must admit, I choose an approach now that really controls the mass of the pituitary tumor so that I don't leave a lot of extraneous tumor that can cause apoplexy. It may justify a simultaneous approach, but I choose the initial approach to try and address most of the mass. So I'll give you this example. It's a 49-year-old man, giant tumor. I thought that there was a little chance for this upper part to drop down through a transnasal approach. So I chose a transcranial approach. Now, it's important to recognize that you can remove the cellular component easily if you choose the transcranial approach correctly. And what I mean by that is I try to come down the long axis of the tumor, okay? And so if you come down the long axis of the tumor, most of the time you'll be able to reach the distal end will be the cella. And you can remove the cellular component by just going through the corridor that the tumor creates. And so I've used that principle as my guiding principle over the last decade or so in these tumors. And you can see we preserve the pituitary stalk there as well. So you can expose and remove the tumor by the transcranial route if you choose your approach. The other thing is that these tumors often have evidence of apoplexy. Look at this tumor. Look at the subarachnoid hemorrhage that this gentleman has had previously. So this one, again, we thought would not come down effectively. At least we wouldn't be able to control the main part of the mass through a transnasal approach. So we'll do a transcranial approach on this tumor. And I think the important thing is remember that the tumor grows from the cella. It can elevate the pituitary gland. And what you want to do in these cases, the challenge here is to preserve the pituitary function. And so what we'll do is we'll come in, and this tumor was wrapped around the anterior cerebral complex, you'll see here. And I'm dissecting the tumor from the region of the anterior cerebral artery. And it's stuck to the subfrontal region. So you're able to remove the tumor from the frontal lobe and dissect it off the A1 segment if you do a transcranial approach. Now, in my hands, I can't do this level of surgery through the nose. So if I feel that I can remove it safer from above and the tumors involving the vessels and encasing them, I will then come from above. So here's now you can see the carotid artery and the optic nerve, and you can go ahead and then decompress. And what I'm going to show you here is you need to recognize where the native pituitary gland is. And it's tougher on the tumors that have that are fairly firm. But what I'm doing is I'm cutting out the tumor, and I'm looking for the normal pituitary gland. And what you see now is there's a difference in consistency. And so I'm removing the gland, or from the tumor from the gland. Here's the gland. Now I'm pushing forward. And then now I'm removing the remaining part of the tumor that's stuck on the gland. I'm trying to preserve the pituitary because I think it's easy to lose the pituitary in removing these giant tumors because the anatomy is so distorted. And so here it looks like a catcher's mitt, but you can see the pituitary gland, and we've preserved that, okay? So what would you do with this patient? She's had a craniotomy many years ago for removal of this pituitary tumor. Now she's got recurrence in her cavernous sinus, extensively in her cavernous sinus, and it's also in her sella, but the majority of the tumor is in the cavernous sinus. So would you come transnasally or would you come transcranially? So, I mean, I've thought about this and I've done them both ways. In this case, I came in transcranially. And this, I just wanted to emphasize that the tumor, if it's a pituitary tumor, it's going to push 3, 4, and 5 laterally in the cavernous sinus. So they're going to be pushed to the lateral. Where you're not going to know, this patient had a 6th nerve palsy, and we don't know where the 6th nerve is going to be. So I'm doing a Dolenk approach here, and I'm finding a window, and this is actually in Parkinson's triangle, into the cavernous sinus. And then it's like doing an acoustic surgery where we're going to decompress the internal part of the tumor and then come around the capsule. And what I'm going to be doing is I'm going to be looking for the 6th nerve, because that's the whole challenge here, is trying to preserve the 6th nerve. We know that 3, 4, and 5 are safe. They're in the lateral wall, being pushed laterally. So we're coming around the perimeter of the tumor. I'm looking for the 6th nerve, and I haven't seen it. And then you'll see how I find it. I find it right there, disconnected. So we can go back to Dorello's canal in this case and freshen it up and do an end-to-end anastomosis. Remember, the 6th nerve and the 4th nerve are very easy to repair because they're unifunction nerves. They control one muscle. The 3rd nerve is terrible, but 6 and 4 you should try to repair at all times if you have the opportunity. So you can freshen it up and then just go ahead and do an end-to-end anastomosis. And she got some improvement in several months. She got improvement in her double vision. So I don't think I could have done this through the nose. I could have gone into the cavernous sinus, lateral to the carotid, and I could have removed the tumor, but I wouldn't have done such a complete removal, and I would not have been able to repair the 6th nerve. So something to think about. Here's her post-op scan. I'll put some fat in the cavernous sinus. That's because, and remember that you can remove the tumor in the cell of this region as well, because you can just follow it through the medial wall of the cavernous sinus which has been breached here, and remove the tumor within the cella. And you'll see her post-op scan that she's had a good removal. There's fat grafting in the cavernous sinus. And then finally, I'll show you this case. This is a case that Chandrasekhar and I did in Mumbai at Bombay Hospital. And I show it to you solely for the reason that you have to be flexible with your approach. And again, I'll use the principle of coming down the long axis of the tumor. And I'm not worried about removing the tumor in the cella, because in most cases that will take you to the cella. This is a young man who had several, he had 2 approaches before. He had transnasal approach, had a very tall tumor, it was very firm, and they weren't able to get it. They did a transcranial approach, and you can see the defect here where they removed some tumor, but were not able to remove it from a frontotemporal approach. So we'll come in transcallosally here. And And then the same principles. So we want to debulk the center of the tumor and gently come around the periphery if you're able to dissect it off the cranium, the cerebrum. And so here's our callosal approach. We're down in the cella now, and the tumor is going into the cavernous sinus on that left side. And so we can stop our approach there. I don't chase non-functional tumors into the cavernous sinus if the nerves are working normal. I usually leave it till after, as a salvage treatment, surgery for a salvage treatment after radiation failure. So we'll go ahead, and we've cleaned out the cella. I'll put a little bit of gel foam and fibrin glue to seal off the opening so they don't end up with a big hygroma. And then here's what you're left with. And I understand from Chandrasekhar that he went on and had radiation for that cavernous sinus component. So a few other tips just in the last couple of minutes. This is something that Ann Osborne taught me about. She said these big pituitary tumors often have cysts around them, and I've witnessed this. It makes a dissection much easier. It's actually loculated CSF, we think, and it's often around these large intracerebral components of the pituitary tumor, and it enables you to, it helps you with your dissection plane.
You have 1 minute more, Professor.
And then finally, this is an important thing to recognize the direction of growth within the cavernous sinus. If the tumor's in the cavernous sinus and you see a NOSP 3 or 4, there's often components that grow at the roof of the cavernous sinus. In this case, it's growing out through the oculomotor foramen. And this component you will not see through a transfemoral approach unless you open up the diaphragm. So if the diaphragm is intact, you will not see this component. It's an important message, and you can see this on in the MRI. This is a cistern around the oculomotor nerve on the left side, and it's obliterated on the right side here. So this is a cartoon. What's happening is the tumor is invading into the cavernous sinus and going out through the roof of the cavernous sinus. Important to recognize, here's a scan that demonstrates this, where you see invasion of the cavernous sinus. And I told this fellow he wouldn't get this part removed. And I went ahead and removed the transnasal part. Here's fat graft, and he had apoplexy in the remaining component. So I don't know what I would do differently with this, but I ended up doing a transcranial approach to remove the rest of this tumor. So finally, this is the last slide. This is a technique that I've used, that if these tumors are soft and you have this large cavernous extension, you can actually give, it's like I call it the toothpaste extrusion technique. So you end up working through the cavernous sinus in these two ports, the anterior loop of the carotid and beneath the carotid. And you can get the tumor squeezed out through there if you do a Valsalva or a bilateral venous occlusion during that period of time. And you can see how much you can remove that lateral component if the lateral wall of the cavernous sinus is intact. It will push the tumor down. So thank you very much. It's a pleasure. I think we have controversy about what to do with residuals in the cavernous sinus, when to treat them, how to treat them, but we're all learning. Thank you very much. I'll leave it at that.
Thank you so much, William. It was a fantastic presentation. And I can see Ibrahim is wishing to ask you something, but let me finish with the two questions we have in the chat. And Jorge Salazar from Ecuador is asking you if, due to this new situation, you have a patient which has COVID positive in your hands, it will contraindicate endonasal surgery nowadays?
So we have a protocol for that. If the patient is COVID positive, and when they become asymptomatic, we wait 10 days when they become asymptomatic and then just go ahead and do it, because it's shown that the virus may be detected in the nasopharyngeal swab, but it's not infectious. So we'll go ahead and do them at that time. If they can't wait, and if they need emergency decompression, then we operate and we use, PPE, N95 masks, that kind of thing.
So in case of emergency, you would go for surgery?
Yes, yes, and we do that. Yeah.
And then Vanessa Caravasili, she's asking you about if you have a patient with an hypothalamic dysfunction, is it an indication for urgent intervention in apoplexy?
Yes, absolutely. And I think we discussed that in the last session. Any visual officer hypothalamic dysfunction, I decompress emergently. And then any diplopia, I don't treat as an emergency because I'm not sure that it makes a huge difference. We've actually published papers where we've treated people with prolactinomas with diplopia on medical therapy, and they have done very well. So I think that's a lesser indication in my mind. And that was mentioned by, I think, Andre.
Yeah, fantastic. And Ibrahim Zweig from Jordan.
Hello, Bill. It's very nice to see you. Long time no see. Very interesting presentation. I have two questions for you. One of them related to a topic that you raised many times in your speeches and conferences about Jehovah's Witness in Salt Lake City and relationship of blood group to pituitary tumors. That's one question. The other question is how much of those giant pituitary adenomas in your series were actually invasive? And invasion here means that there is histological evidence of invasion, either brain invasion or high Ki-67 or whatever. And what was the need for radiotherapy for those invasive giant pituitary adenomas?
Right. So those are all excellent questions. So the majority of them are invasive. In fact, the gross total resection rate is reflected in that because the usually cavernous sinus invasion. The histology of the tumor, as you know, with pituitary tumors, they can be very invasive, but they're not necessarily aggressive in their growth pattern. But these prolactinomas, the giant prolactinomas, can be very invasive everywhere. But again, they're benign in their histology and their growth pattern. So a number of them, the way we do it is we individualize. We present the patient postoperatively to our tumor board with our radiation therapists, and we look at the size of the tumor that's residual, where it is, and then decide whether we'll radiate now or wait. And you know, usually, and I think that's a controversial question, is when to radiate the cavernous residual. And I'd appreciate people's thoughts on that, because we've been often delaying radiation to try and preserve cranial nerve function better in these patients. But I just don't know the right answer to that question, and we're looking at that right now in our own series, but I'd appreciate your thoughts on that.
What about the Jehovah's Witness issue?
Yeah, so we have Jehovah's Witnesses here in Utah. The predominant culture is Mormon, and there's no problem with transfusion there. But Jehovah's Witness, obviously, they don't want transfusion. But we're not too concerned. Most pituitary tumors, we don't need to transfuse. I mean, it would be a very rare pituitary tumor that we'd have to give any blood to, even a giant one, because you can usually manage them quite well. I can't recall ever, in fact, in the last, in this whole series, whether we transfused anybody at all. So certainly meningiomas, but not necessarily pituitary tumors. Yeah.
They sometimes accept the cell saver technique, but there are Jehovah Witnesses that also don't want to have a cell saver because they don't want the blood cells to leave the body and to come back. So right. The cell saver is a possibility.
In America, we can't use a cell saver because it's a neoplasm. So
but we don't do it for malignant disease, but yeah. For, let's say, in cranios, meningiomas and pituitaries, we can do it.
Yeah. Yeah, we still they won't let us do it here. Yeah.
Okay.
So there are two more questions, William, if you don't mind to answer them through the Q&A chat, and we can keep going. Thank you so much again. It was fantastic to have you here. And Imad, whenever you want.
Okay, well, now will be Fred. I know he is ready for his presentation. Professor Fred Gentili, a close friend, and called him brother for many years. He is a STEM member of the World Federation Skull-Based Society. He has contributed to education and to advancement of this field. Interestingly, we always count him as a skull-based surgeon, but he shifted gears, but he complemented his skull-based experience with microsurgery to add the endoscopic neurosurgery. He is so advanced with his expertise, has published a lot of papers, and he is always a favorable member of most of the society. Like he's from Toronto, and I'm looking forward for his presentation. Fred.
Thank you very much, Imad. Can everybody see the screen?
Yes.
Okay. So my talk this morning is on the management of craniopharyngiomas, and I was asked to see.
I cannot see the screen sharing.
It's not shared.
We see you.
Minimize it. Let me just escape.
Can you see it? Anyone can see the?
No, it's not shared yet.
No, the screen is not shared.
Okay, let's see now. Here. Minimize. Now, let me say share screen. Is that
Yes.
better?
Perfect. It's coming.
Yeah, you're sharing. Right?
All right.
Okay, here we go. All right.
Yes. All right.
So my talk, as I said, is on the management of craniopharyngioma, and Imad said how I do it. So, you know, there's a lot of controversy in craniopharyngiomas. One of them, of course, is open versus endoscopic approaches. And you can see I crossed this out now. I think this makes for very good drama at meetings, but I think we're over this now. After a decade, we realize for this very, very challenging tumor, we need both endoscopic and cranial procedures. There's no open versus, it's a complementary thing. But I must say that the endoscopic approach is really, I believe, superior most of the time, if I can say that. Why is this a very formidable lesion? We all know this. This is a medical school issue. These are rare tumors, very surgically challenging because of their location, basically. And while surgery remains the primary form of treatment, we all know, if we are honest, that total removal remains difficult. Maybe if you can do it in 50 or 60% of the time. And because of this, there's very significant high recurrence rates. And some would say if you follow these long enough, they're up to 70 or 80% will recur. Now, there are many, many surgical approaches for this tumor, many open approaches that we all are aware of. We all learned these in our residencies, and then the unilateral approaches that are used for these. And now, of course, we have, over the last decade, the pure endoscopic approach. Now, there are many controversies in craniopharyngioma, as you can see here, and I'll briefly, I don't have time, of course, to do all of these, but look at, what is the best surgical approach? I basically told you that. What is the best surgical strategy? That is very important. Is it really radical excision at all cost, or a more function sparing surgery with possible need for radiation? And then just as this is my little caveat to the issue that, my question is it really possible, I've only wanted to know, to remove a craniopharyngioma totally and spare pituitary function? That is, remove it totally and spare the stalk and pituitary function. I have my own views on that, and I'll tell you that. Don't have time about pediatrics and adults. And then just I'm going to finish off with the issue of recurrent craniopharyngioma, because they're a real challenge. They occur often. And then the issue is, how do you deal with this? Repeat surgery, radiation, medical therapy, etc. So what about the best surgical approach? Well, this is my sort of experience over the last decade. I really have gone over from the open to the endoscopic approach. You can see here the last 30 patients virtually, from basically 5 to 1 to the endoscopic approach, both for primary lesions and even recurrent lesions. The answer to your question is why? Why have I done that? Well, it's because of this. This is a patient that presented back in about a decade ago, 76-year-old with this craniopharyngioma. And what approach? The standard approach for this was basically an open approach at that time. And these were either you did a terional, you did a subfrontal, you did an interhemispheric, you did a supraorbital. These are all very good approaches. We all use them, but there's a problem with these approaches for these craniopharyngioma, which are retrochiasmal interpeduncular, is access. You have to work through the lamina terminalis, you have to work through the prechiasmatic, and it's very difficult to access these large tumors. And so this patient was initially done through a pterional approach. As you can see, they were not able to really get very much of it at all because they were concerned about, injury to the optic nerve. So then subsequently, they sent this to me, and this is with the endoscopic approach. And you can see, to me, this is like a different planet that you're on. The ability to see these, the visualization that you see is very significantly better. Here we are taking it off the medial wall of the cavernous sinus. And this is from the chiasm. This is because of the previous cranial procedure. And of course, this is after the gross removal. Of course, this patient was 68 years of age. We're not going to be really crazy and try to remove everything from the medial wall of the hypothalamus. And so this patient, we left this, as you can see here, he's 8 years stable disease. So there's no question in my mind that the expanded endoscopic approach for craniopharyngioma has significant advantages. These are all the advantages that you see. This is the most direct approach, excellent visualization, reduced manipulation of the vascular structures, neurovascular structures. And to me, it's this easier access to these retrochiasmal, interpeduncular, often tumor extension. Disadvantages, we all know. Every approach that we have has advantages and disadvantages. And the endoscopic approach really has a restricted approach. The workspace is very challenging. And the whole issue of CSF leak, which we've done, I think have made significant progress. But anybody who tells you that we've solved the problem of CSF leak and expanded approach is not correct. We still have an issue with that. And then there's a learning curve. And a certain prerequisite for expanded approaches, I always use my ENT colleagues. I think it's very important to have a knowledgeable anatomy. And of course, it's a bimanual, microsurgical technique. We are neurosurgeons, we are bimanual animals, and we have to do this in a microsurgical approach. So this is the anatomy of the transcellular transtubercular transplant approach for meningiomas. As you can see here, this is the anatomy here. This is just the anatomy from a dissection from one of my former colleagues. And this is at the surgical exposure, very similar. If we look at now with removal of the bone, you can see the optic carotid, at least the paracellular carotids. You can see this is basically the exposure we made for the craniopharyngioma. It's really a rhomboid kind of exposure that we do. And then this is the view that you basically get once you've had that exposure. So now I'm just going to show you, and as Ahmed said, how I do it. So I'm going to show you how we remove this craniopharyngioma endoscopically. This is a 68-year-old woman presenting with headaches, visual disturbance, cognitive disturbance, as you can see here. And with this large craniopharyngioma, cystic component, very large, going up to basically to the ventricle, into the third ventricle, and so it's a solid component. So here we go. Basically, we do a middle turbinectomy on all these patients. On one side usually is sufficient. Sometimes we do two sides. The key is exposure. And here, then after the middle turbinectomy, is my ENT doing showing basically the maxilla, doing the to allow for the medium sort of maxillotomy. This is the bullae, and we basically, this is showing the shaver doing a bulectomy. This is all to give you this wide exposure here that is necessary for these expanded approaches. Following this, basically, this is the posterior ethmoid that we see here. And now we're into the ostia of the sphenoid sinus. And then following this, we do then, very important, is the nasal septal flap. Ahmad showed this, so I'm not going to waste time here, but this is a very important component of the closure for CSF, prevent CSF leak is the nasal septal flap. And then we'll just very quickly go through this. And this is the upper cut that we try to leave a little bit of mucosa up there to spare olfaction, but it's not always possible to spare olfaction on this side. And then here's the flap is a very nice thick flap that we use. And after this comes down, you see now this is the keel of the sphenoid that we see. And now we do a posterior septotomy to allow for our bimanual, binostril technique that you can see here. And then the other issue, because of on the other side, we have mucosa, we do a second flap. This flap on the other side can be used as a reverse flap, or sometimes you just need it also to help with the closures. This is, we are taking the other flap. And then finally, we're here now looking at the sphenoid sinus. And the key here is you want to drill down all the septa. You want a very nice, clear view and exposure of the cellar, at least of the sphenoid roof. And here's the tuberculum, here's the planum, here's the optic prominences, here's the carotid artery. You can see here very nicely. And we thin these out very thin, and then we basically do our bony removal. And here we are now just opening the dura open itself. We remove the sella because this allows us sometimes to displace the pituitary gland down. We do not do a transposition. Imad, I think, alluded to this. My belief is a transposition of the pituitary means pituitary panhypopituitarism. That's my own that's been my experience with that. So we don't transpose the pituitary gland. Here we are now. This is now, we see the optic chiasm very nicely. We remove the dura right over to the optic canal. And now we do the dissection, as you can see here, using basically a bimanual technique, as you would be doing basically under the microscope. And now I'm not gonna bore you with just the dissection, but what we do is, like you would under the microscope, we remove the solid component of the tumor. Showing here, just very quickly, I'm going to go through this. And here we are. And there's the pituitary stalk that you can see on this side. And here, just let me show you here. As I remove this. There is the mammillary bodies. You can see posteriorly, you can see the pituitary stalk here. And then at the end, as you go in, we saw that large cystic component here. What we see here now is the third ventricle. And we see the tumor capsule basically stuck to the walls of the hypothalamus, the third ventricle. And to me, somebody who's 68, an attempt to remove all of this is really foolhardy. There's no way that you should attempt to do this. So basically, this was left. Now, the reconstruction is very important in these. We use a multi-layer technique, inlay fascia lata. I always use biological material. I don't use synthetic material. These are an onlay now fascia lata that we see here. This is followed by a nasal septal flap that we harvested, and some Surgicel, some Avicil, and that's our closure that we do. So this is this patient, as you can see here, 3 months after the ventricles were down. He has some residual disease that you see here. She was cognitively normal. Her vision came back to normal. What do you do now for these? So I basically observe these. And this patient is now 2 years stable, but we know that there's a definite chance that this patient may recur, so we watch him very carefully. This is a 45-year-old patient with visual decline, virtually blind, as you can see here. What's the approach? Well, to me, there's no other approach now than the endoscopic approach. And this, again, very quickly, I'll go through this to show you this, a solid cystic, the same exposure that you see here that we did before. And then I just want to show this because of the importance that I think that this endoscopic approach allows. It allows us basically to visualize the optic chiasm and the vascular structures. I think this is very critical to spare these superior apophyseal vessels, which I think, there are visual disturbances after surgery for craniopharyngioma. And I think the problem is not necessarily manual manipulation, but is vascular insult. And the endoscopic approach, I think, improves our ability to minimize that. This patient very surprised me. As you can see, from virtually blind to 20/20, 8 years, no evidence of recurrence. And I can show you these. You can do larger tumors, very smaller tumors, and get a nice resection in these. However, like anything, as we've seen in pituitary, there are limitations to the endoscopic approach. And these are my limitations. Obviously, you're not going to do this endoscopically or this here shall endoscopically. So lateral extensions, neurovascular encasement, purely intraventricular, I don't think is it's a good approach. And of course, surgeon's experience and preference is very important. So this patient here, 39 years of age, young man, significant visual dysfunction with this large tumor, which maybe some of my endoscopic colleagues would do it endoscopically. To me, no. This is a very narrow stalk that you see here, going laterally, superiorly. So I did this using a transcallosal transventricular approach that you can see here, allowed us to get a nice resection of this tumor all the way down. However, you see that we left a very small at the very end of our exposure. Patient did very well ultimately, and we watch him carefully with these. And as not surprising, at 1 year, he had a rapid visual decline, a cystic recurrence. They can see here what approach now. Well, there's no question here. This is now an endoscopic approach to remove this. In this patient now, I think 5 years, no evidence of disease recurrence. So what is the best surgical strategy? And I have to talk about this because this is part of how I manage these. From a radical excision to a more subtotal functional sparing excision. And this is based on the issue that over the last decade, if we look at the issue with craniopharyngioma, both in pediatrics and in adults, there's been a definite pendulum swing from a radical excision with significant endocrine, hypothalamic, morbid obesity, neurocognitive decline, and significant poor quality of life to a more conservative sparing, function sparing modality with radiation, where you address the problem. If the patient is going blind, then you deal with the vision and as much as you can, but in a function sparing procedure. Now, some people will say, well, this is going to allow higher recurrences, multiple procedures, and radiation side effects. Well, the literature does not necessarily agree with that. If you look at progression-free survival between gross total removal and subtotal removal and radiation, as well as overall survival, you see that there's not really a lot of difference. And so when we make decisions with regard to how radical we're going to be, we have to keep these in mind when we have our surgical decision making. So this patient here, 63 years of age, visual dysfunction, had normal endocrine dysfunction with this craniopharyngioma, nice, not that small. What approach? Well, this one I did endoscopically. He had improvement in his vision, but despite my attempt, he was hypopit. This patient postoperatively, as you can see, had a small residual here in my attempt to spare the stalk. And what do you do with this? So we observed it in 3 years. However, 2014, you see a significant increase in this. And then at that point, we radiated him with IMRT. And now this patient is 4 years. You can see significant reduction in this tumor, and the patient is quite stable. So I think, with regard to radiation, as surgeons, we do not like generally radiation, but there are times where, we have to understand its effects. And if you look at the long-term results of fractionated stereotactic radiosurgery in craniopharyngioma, we see, and this is in looking at follow-up of a median follow-up of almost at 10 years, that the local control rates are quite high. We can't deny these results. And the overall survival rates, as you can see here. So I think we have to keep this in mind. That's what my point is I want to say here with regard to radiation. Finally, second finally, is it possible to remove a craniopharyngioma totally and spare pituitary function? My belief was the answer is no, from my experience with open surgery. Now with the endoscopic technique, I said, does this maybe will allow us to do that? And just show you one case. This is a patient with this small, nice, soft craniopharyngioma. And this is exposure. You've seen that now, so I'm not going to bother with the exposure here. This intracavernous sinus, you always have to coagulate as you go in and do it. And this is after the removal. Now, everybody would love this case. This is a soft tumor. It's dissectable. There's no calcification. It's eccentric to the pituitary stalk. So this is a type 1 in terms of Cassam's classification. And so we're able to come here and then basically we remove the tumor. And so my feeling is now, I said, well, now with endoscopic approach, I think that maybe we're going to be able to spare the stalk and spare pituitary function. So this patient, as you can see, he did have a CSF leak, required a lumbar drain, but that was fine. But improvement in his vision, normal pituitary function after transient DI. 3 years, this patient looked like he's cured. 3.5 years, increased visual dysfunction. What happened? Cystic recurrence right in the area of pituitary stalk. And how did, what did we do here? Obviously endoscopic, went in, removed the stalk and removed the tumor. This patient's second surgery that you see here. So my belief is still that the answer to, and in medicine, you can never say never, never say always, but it's rarely, if ever possible, to remove a craniopharyngioma totally and spare the stalk pituitary function because of the embryology of these tumors. They are, that's where they originate from. So I think here you need patient engagement. That means you have to talk to the patient before. You can say, yes, I can go in and try to remove this all, but you're going to have pituitary dysfunction, taking pills the rest of your life, or I can deal with your vision problem and try to remove as much safety, try to spare the stalk, but there's a risk of recurrence that we can then deal with radiation. Finally, the management of recurrent craniopharyngiomas. This is a real problem. You can see here, as I say, some people would suggest if you follow them long enough, it's very, very high. These are difficult problems. These are the factors related to recurrence. So let me show here. Why do craniopharyngiomas recur? Well, this is why some of these recur. This is a patient with a craniopharyngioma that I showed you. And here's the exposure, same exposure. You've seen this now many times. But look at the lesion that we see. This is a craniopharyngioma. Look at its capsule, the A1s that you see here, the chiasm that you see here. There's no way in the world that you're going to get a total removal of this tumor. Nevertheless, you can still do a very nice resection, as you can see here, basically, as we come on, do a very nice microsurgical resection as I take the tumor off the optic chiasm. As you can see very carefully using microsurgical technique, ultimately we're able to do a nice resection off the chiasm showing over here, there it is, as we're taking it off very nicely. You can see the PCOM going back here. Here's the pituitary stalk that here, but the fact that I'm not going to get a total resection, it's crazy to try to then, take the pituitary stalk. So I try to spare the pituitary stalk. And then this is here after the resection. So this is the problem. You know that a patient like this has a definite risk for recurrence. And this is patient, as you can see, no CSF leak, improvement in his vision. And now this patient is residual. We know that there's residual. And what do we do? You observe them, radiation. What is the right decision? My general feeling, I watch these patients. At the first sign of any recurrence, then I will consider IMRT. So this is our series that was published just about a year ago of 43 patients. This is and I think we have to show results in this situation. You can see here that the recurrent lesion in our series was already 50%. So we're already behind the 8 ball when 50% of your lesions are recurrences. The average size, as you can see here, and this is basically our gross total removal rates, was only 44%, less than 50%. Because of the recurrences, the primary lesions, we were up at 73%. And when the objective, because sometimes in those elderly patients, your objective is not to get 100%, was actually 81%. But look at the gross removal rates in recurrent lesions, 10%. And this is an honest issue that very, very difficult. If you can't remove craniopharyngioma, gross removal for the first time, you're not going to do it the second time. It's like chordomas. Very, very, very satisfying visual outcomes, 95% stable or improved. The only one worsening had previous radiation therapy, and I think it was a vascular insult. But very interesting here, just to show you, the mortality was 0, CSF leak 21%. With the nasal septal flap, now we're less than 10%, but as I told you, it's not solved yet. But look at the median follow-up. This is very important. 56 months was the median follow-up. The recurrence rates from up to 2013 was 14%. However, we decided to stop and not publish, but wait another 2 years. We had 2 years to watch the patient. So if we had published at this time, we would have said recurrence rate 14%. Look at what happened in another 2 years. Another 9 had a recurrence. So all told, with 35% recurrence rate. So the key that I'm trying to say, the importance basically of following these patients because the recurrence rates will occur. So in conclusion, and this is based on evidence-based review, using a level of evidence, rate of recommendation that you can see here. The management of craniopharyngioma, I think, still remains a very surgical challenge, regardless of the approach. Craniopharyngioma should be considered a chronic disease like rheumatoid arthritis. While gross total removal may be associated with reduced recurrences, the focus, however, should be on the quality of life in long-term survivals. Craniopharyngioma do not kill people like cancers do. They live for 20 years. And if you have a patient with a terrible quality of life living, that you have to keep in consideration. No question in my mind that the endoscopic approach is really a significant addition to the transcranial procedures. And for me, in carefully selected patients, it's really a procedure of choice with less morbidity and a higher rate of visual improvement. And we cannot forget that the subtotal removal and radiation therapy is a valid strategy, especially in cases where attempts at gross total removal would carry significant risk to the patient's quality of life and can provide similar progression-free survival, overall survival with less morbidity. So thank you very much for your attention. So no one surgical approach or strategy can be considered the best approach in all patients. Each patient is best served by the formulation of a tailored, individualized surgical plan, taking into account both patient and tumor factors. Thank you.
Thank you.
Thank you. Thank you so much, Professor Gentili, for sharing with us your huge experience on this challenging topic. And we have many questions, by the way, and still having 2 questions for William Caldwell in the Q&A. So if you don't mind, if you can go through them. And there is a specific one also for you from Abdallah Mohammed. It's a long one, so I would appreciate if you, Fred, could have a look at it later on. And let me ask you 2 short questions. We have one is from Harshad Parek, and he's asking you about the use of endoscopic approaches for those craniopharyngiomas which are extending both para and retrocellular. If yes, how would you do them?
Yeah, so retrocellular, no problem. It's like doing a chordoma, whatever, definitely endoscopic. And I showed you some of those going back. Paracellular, absolutely. There you have to be careful. And what I will do, and I was going to show, I didn't have the time today, a lesion going lateral in the middle fossa, no question. For me, that's an open approach. So I will do that, a terional approach, whether you want to do a mini eyebrow. So lateral extension to me into a middle fossa, open approach.
Perfect. And then we have Javier Abarca. He's asking you about the use of fat for reconstruction and also about external lumbar drainage, elective ones after surgery.
Very good. That's a good question. It's always the same question. We don't use fat. Interesting. I shouldn't say that. The key for me is the multi-layer closure that you see there. An inlay fascia lata, onlay fascia lata, and then the nasal septal flap. If you want to then put some fat around that, you know, that's fine. I'm always worried about putting a lot of fat inside there with the chiasm and so forth. I never know whether you're overpacking and whatever, so I don't use fat. Never lumbar drainage. And the controversy has gone back when we were doing open approaches back 25 years ago when I was doing the craniofacial resections that you young people don't even know what they are. But we used lumbar drainage. We realized the significant potential problem with the major pneumocephalus, tension pneumocephalus. We never used them with open, and I've never used them routinely in endoscopic. Now, when I get a lumbar, a CSF leak, I say, shit, I should have used a lumbar drain. But the issue is that it does not, and now there's been studies out looking at it, it does not really make proven any significant difference in terms of CSF leaks using a lumbar drain. And the risks are, as you say, if you have a leak, you're going to get pneumocephalus and tension pneumocephalus, so no lumbar drain.
Thank you. Thank you so much, Ibrahim. Unmute, please. Can you unmute? Ibrahim, we cannot hear you.
Thank you, Fred. It's nice to see you again. A very nice presentation, and I know your views about craniopharyngiomas, and I'm sure you know my views too. I was glad to see that you put open surgery and endoscopy, not versus, because there's no fight between microsurgery and endoscopy. The question is really whether one should go for radical excision or one should go for partial excision. And that is the question. I think it is the state of mind of the surgeon going for surgery. What is exactly his plan? You cannot decide that you are going to do partial resection beforehand. You only decide it intraoperatively. What is against totally eradicate the tumor when you are there. Pascal and so many other authors showed us that radical excision is possible. And I have a large series where radical excision was not followed by any problem and they did not need any radiation. My point is this: if I am there and I can do radical excision, there's nothing against it. I should not stop because people say that you go for partial resection followed by radiotherapy. So I'm not against partial resection and radiotherapy. And again, you mentioned that one should not go for radical excision at any cost, because this is not the case. But I say it is a state of mind of the surgeon going in to decide intraoperatively whether he can go for radical excision or not. Radical excision is good. You take away all the disadvantages of radiation and many procedures thereafter. Thank you very much again.
Yeah, so the problem with that, Ibrahim, the problem is that what you say, radical excision still results in recurrences. If you look at the whether it's the reports, even after radical excision, 35% recurrence rate. So what you think is a radical excision is not a radical excision. But I will always say, you have to be happy with your results. But the reality of it is more quality of life is very important. Patients, and you have to follow your patients. The pediatric neurosurgeons have gone away. Why have they gone away from the radical excision? Because they see more of them. They realize that the morbidity, even Yassergill in his series, go back to Yassergill's series, almost 80% all had pituitary insufficiency, and you have to follow these patients. Be an endocrinologist because they do have visual, they have pituitary endocrinology problems. Like I showed you there, if you get a radical excision of a craniopharyngioma, you've taken the stock. You cannot get a radical removal, total removal of a craniopharyngioma and spare the stock. So then that means, fine, I got a radical excision, but the patient is pan-hypopit. And I told you now what I do for my patient, and I have that young patient, I say, listen, I'm gonna, I can remove this all. It looks like I can remove it all, but I'm gonna have to take your stock. Now, do you want that? That means, however, that you're going to have to be taking thyroid, cortisol, estrogen, progesterone, not estrogen, progesterone, for the rest of your life. And I said, do you want that? Or I will try, but the likelihood is I may have to leave a little bit of there, and therefore, you may have a recurrence. Some patients will say, no, I don't want a recurrence. It's psychological. Take everything out of it, and that's fine. I say, great. I have no problem. But another patient will not say, no, I do not want, to be taking a pill. If you deal with my vision, that I'm going blind, and then if you have to, and I tell them about the results of things, then, so to me, the patient is a very important component of the team. That's when I said you have to take patient factors in mind. You may have patients who tell you, take this all out. I don't care what happens about morbid obesity or whatever, hypothalamic dysfunction, take it out, fine. But you have to, engage the patient and understand that. That's all I have to say.
But Fred, recurrence is higher in partial resection, followed by radiotherapy and whatever, more than the radical excision. No, and they have the same problems. Literature tell us.
Maybe in your experience, look at the literature. I showed you the literature saying both in adults, the literature now in the adults, look it up, and pediatric. There's no difference between gross total resection and subtotal resection radiation. No statistical difference. And that's why the pediatric neurosurgeons have gone over to the less radical excision. So you must go to the literature.
I went to literature, Fred, and I agree with you about many of the things that you said, but I disagree about that radical excision must not be attempted. Radical excision must be attempted if you can, because that would reduce all the side effects of radiation.
You misdirect me. I do not say must not be done. In the end, as a surgeon, you have to decide with your patient to make that decision.
That's my point. That's my point. Exactly. That's my point.
I'm not telling you that you have to look at the literature and see what the results are.
That's great. We are 4 minutes late, and I really appreciate, Professor Gentili, that you put the patient as the key of the team. So
Yes.
thank you so much for your vision. And the number of questions is growing and growing. And we know you have someone in the OR waiting for you.
Exactly. I'm doing a meningioma that people say should never do endoscopically, but I'm doing one. Listen,
So good luck.
I apologize. I have to leave. All my friends are my great friends that I see you all. Thank you for doing it. And we hope to see you again, and maybe next time face to face. I don't know when that will be, but I hope it will be. Thank you very much.
Thank you. Bye-bye. So due to our 5 minutes delay, if you allow me, we will keep going and we will introduce the next speaker. So Kasadi, if you are ready, you can share your screen. And our next speaker for today's session is a worldwide known African neurosurgeon who is mainly established in Harare, Zimbabwe. He's Dr. Kasadi Kalangu. He's professor and the head of the Department of Neurosurgery at the University of Zimbabwe. And his professional interests are spinal surgery, head injury, brain tumors, as well as pediatric neurosurgery. And he's part of a number of journal editorial boards. And he has widely demonstrated his interest in global neurosurgical education. It's my great pleasure to give him the word. And he will continue the session discussion about the treatment of pituitary tumors with suprasellar extension. Thank you so much, Kasadi.
Thank you, Pablo. Can you see my screen?
I can see myself.
We can see a big Pablo.
Now, let's see.
Can you go to your PowerPoint?
Yes, here we are. I have it.
Perfect.
Good. Yes, I've opened. I can see it for me. Do you see it?
Yes, we see the slide number 20.
Okay.
Kasadi, we cannot hear you properly. Can you... there are some issues with your connection, I guess.
Or it could be that when you share the screen, maybe an issue with the audio settings of it as well, Pablo. We can see it, but we can't hear Kasadi.
Oh, okay. Yes. I have my power. Can you see that in my PowerPoint?
Yes.
Yes. Perfect. Now
you can see now. Okay.
You can go to presentation mode if you want.
Okay. Let me put it on.
I think the audio is not working properly once you share your PowerPoint.
Okay.
So, Kasadi, do you mind to restart your computer and the Wi-Fi connection to check if it works properly, and we can go with Professor Grottenhuis? He's asking me, by the way. Because we cannot hear you, Kasadi.
But it is there.
Yeah, he's there, but the thing is that the audio is not good. So we are not gonna be able to follow it. If you are hearing us, Kasadi, please switch and restart your Zoom and your PowerPoint, and we will be with you in 20 minutes. Andre, it's okay if you go next?
Yeah, well, okay.
So
we'll go next.
Ramesh, can you introduce our next?
Sure. It's a great pleasure to invite Professor Andre Grottenhuis from Netherlands, working at the Radboud University. He's a well-known neurosurgeon and the program training director at the university as well. And I'm very eagerly waiting to see Andrew's presentation on the anatomy of the intranasal approach. The whole theme is intranasal endoscopic approaches, and it'll be good to see the anatomy and the nuances of the approaches as well. Thanks, Andre, for the talk. You can start now.
Yeah, well, thanks, Ramesh, for the introduction, and Imad and Vladimir for the invitation. Actually, I think that for the younger ones, you already have seen the application of what I'm telling you. This is really now about anatomy. So I have no disclosures. I'm an emeritus. I'm not involved in anything anymore. So I will indeed review the anatomy, endoscopic anatomy, and then show you just a brief video of the surgical technique that will bring back all of these anatomical parts, and then have some conclusions. Just to remind you why we are switching, or have switched, from the microsurgical technique, at least that I learned in the 70s and 80s, to the endoscopic approach, because it brought in the light into the dark space of the nose. It has a panoramic view, so way larger, because there was no restrictive speculum. It was more easy to move your instruments, and it resulted also essentially in a reduced surgical trauma. But from the beginning, at least for my part, I always adapted a binostril endoscopic approach compared to the mononostril. That means that you only go through one nostril, but you still have to detach the septum and then do a bilateral sphenotomy, because otherwise you can't deal with the lesions. Essential is a lens scope with some irrigation. It will otherwise damp very easily, and the vision will be blurred. So if we look in a kind of practical way to the endoscopic anatomy, I always tell my residents that it is, you have the anterior part, which is from the frontal sinus to the posterior part of the ethmoid. Then you have the middle part, which is all about the sphenoid and sella itself. And you have a posterior part from the dorsum cellae down to the clivus. But due to the time, I will not address that one, because this would go into very, very more issues, and it would never be possible to cover that in 20 minutes. So the anterior part, the first part of the nose, let's look to the nasal cavity. When I learned transsphenoidal approaches, it was getting that speculum as quickly into it, down to the area that we felt familiar with. That was the sella. The nose itself was not so well known, but we have to realize that the nose is the most superior part of our whole respiratory tract. It has a nasal skeleton, and it is has two functions, respiratory and olfactory. So the functions are so important. I can't discuss anatomy without telling about the functional anatomy of it. While we are sitting here and discussing and talking to, well, not to each other, only through the screen, we have to realize that it first, everything we inhale, it will be warmed and humidify. That's so important. And at the same time, the nose is able to remove and trap any kind of particles that we inspire. And of course, we also know that it is essential for the smell, a sensory function that is really essential for our human beings. And of course, it is the place where the sinuses will drain and clear the mucus. So if you look roughly to the nasal part, you see that the respiratory area is, of course, the largest. The vestibule, which is the entrance, is the smallest part. And the olfactory region, that's in the apex, that's in the higher regions. So the nose is actually more the area from the entrance, the vestibule, to the nasopharynx. That is the nose. That is the area we are now dealing with in endonasal endoscopic surgeries. If we look to the medial wall, then we have, you have to realize that the largest part is actually part of the ethmoid bone. The anterior part, as you can see here, is cartilage. That's the only cartilage we have. And the longer part, the longitudinal part, is the vomer that attaches to the palate. So if we look now to the lateral wall, so on both sides we have lateral walls, that is the middle wall with the septum. The lateral walls, we see these extensions, and these are the turbinates or conchae. And the two major part of this, superior and middle, are part of the ethmoid bone, and the inferior turbinate is, and sometimes we say it's like the three fingers. So your inferior turbinate is like your middle finger, and the middle finger, the middle turbinate like your index finger. So this is, the length of it is usually, at least by us as neurosurgeons, underestimated. Because of this subdivision, and that's very important, we have areas, it increases the area of the epithelium of the nose. And this is not only stratified and epithelium, but these have these so-called goblet cells that are secreting mucus. But because of these turbinates, we have areas where we have the flow. And the interesting part is that it is built that way that the laminar flow that comes into the nose is slowing down and becomes turbulent. So it stays much longer inside. So the area is increased, and therefore we have more possibility to remove particles and pathogens and also humidify and warm the air that we breathe. So they are very active organs, and we don't realize that. I think that hardly any one of you know that about every hour on one side, the turbinates start to swell, and we don't use it for air passage. It's only the other part. And then after 1 hour, the other part swells, and we use the other side. And that is, it's also resting. It's such an active and functional system. And I only tell you this to realize how important it is and how we can tamper with this important function when we start operating it. When I started in the early 90s, 1994, I did my first endoscopic pituitary with an ENT surgeon. And I thought we can just remove that all to get access. But he told me never to do that because it's so essential for the function of the nose. And of course, also the drainage. We don't see that a lot, and only if you do it yourself and go further and do ethmoidectomies, you learn the importance of the semilunar hiatus, where actually the frontal maxillary and the anterior ethmoidal sinuses drain. So always make sure, that was always at the end of the surgeries, I make sure that that is not blocked by any debris. I don't place anything because that will cause sinusitis. So the drainage, of course, from the sinuses through the nose is essential. Now to the vasculature. I mean, vascular supply and innervation. These are the things we have to learn when we deal with any kind of structures. You see that from the roof, we have the anterior and posterior ethmoidal arteries. This is not actually one of each. You have more of them. Some there are duplicated, triplicated, so there are more of them. They supply from above. Then the palatine arteries supply from below. At the same from the labial, from your lips, the labial arteries supply that. And altogether, these arteries And the same you see here from the back, and we know that from the flap. Everyone knows it from the Basagetico Haddad flap, that the sphenopalatine artery is important. These 5 arteries have anastomosis. They connect together. And ENT surgeons know this very well because nasal bleeds are more typically located at the area of this anastomosis, which is called the locus Kieselbachii, the Kieselbach area. And in the Anglo-Saxon area, it's also known as the area of Little, but it is the Kieselbach area that they have to coagulate if there is a nasal bleed. Just remember this. This is just plain anatomy, vascular supply. And now innovation. I mean, innovation are 2 parts. First, it is the sensory innovation of the area itself, like let's say the skin of your nose, that's trigeminal artery. You have the nasociliary nerve, then you have the nasopalatine nerve that comes from the maxillary nerve. But of course, the most important part of it is the whole olfactory innovation. You know that the bulb is it's part of the brain, and we always call it the first cranial nerve, but still it is actually brain, because the real nerves are these. These are the little nerves, the olfactory nerves, the nerves that come from the bulb and go through the lamina cribrosa. All these little tiny holes contain nerves, and you see that it is quite an area of the nose that is involved in olfaction. So tampering with this could affect that sensory function. And therefore I wanted to show this picture. So when we use an endoscope and look into it, it's a typical going inside and then down, up. It's a kind of like diving into the water and coming up again. That's the way you do it. When we look initially into the nose, we see the inferior turbinate. We look for, when we pass it, we see the middle. We go below the middle turbinate, farther down until then we will see the choana. And from there, because the shaft of the endoscope is rounded, we can move up, we can dive up out of the water again, and then look upward, because the ostium of the sphenoid sinus is in the upper part of the sphenoid sinus. It's not low. The ostium is always there. There has never been a case of a non-ostium, that there was the no ostium. The thing is that it is only in about 40% it is visible. In 60% it is covered with mucosa. But you have to know that it is there. So don't worry, you always find the ostium. And that is how it looks endoscopically. The inferior turbinate, if you look into the nose, that's the part you see first. Nasal septum here on the right side, so we are on the right nostril. If you pass the inferior turbinate, you see the middle turbinate, so between them and the septum, and in the depth you see the choana. So that is the initial way to go, the choana, and then you move in this way, the sphenoadenoidal recess and middle turbinate. If you move your endoscope up there, you see this sphenoid ostium. These are the only parts of anatomy that we need to know for a standard pituitary approach. So I'm not going for extended approaches. I will not tell you about the draft 1 and 2 and 3 approach to the frontal sinus and how to do extended approaches. That would be too far. But this is the typical pituitary approach. It's actually a very quick approach. It's very easy to follow that. So when you have done this, you will then enter the sphenoid sinus, and that's the middle part of the skull base of the area we want to go in. So if you look on the left side here, so middle turbinate again, of course this is enlarged, the ostium is enlarged, actually the ostium that you saw in the previous image is only very small, but it is in fact way larger. You don't, it's just moving the mucosa down. You have a longitudinal ostium. But if you enlarge this, you come into the sphenoid sinus. And that sphenoid sinus, you see the posterior wall and you have lateral walls. And typically what we see are all these different protuberances in the posterior wall. And the good thing is that they guide us to where we have to go. Because the cella, the cellar floor is in the midline. How do we find it? Well, we have typically the protuberance of the optic nerve on both sides, then the bulge of the carotid artery, and we have the indentation of the clivus, and then we have this between the optic nerve and carotid. We have the medial optic carotid recess, and we have the lateral optical carotid recess. That's not always there, I have to tell you. It's not always there, but it is so important to see that, because above the optic bulges, here we have the planum. And in between, a little bit more dark, is the tuberculum cellae, which is a thicker bone. So these is the typical appearance of the sphenoid sinus. So it can be like here, you see on both sides, you see this recess, and a midline septum. I refer to that as the bulldog type of sphenoid sinus, where you have a clear indentation of the clivus. Here, the paraclival carotid arteries on both sides, and the carotid bulge, optic nerves. This is the easy way. Sometimes it's more shallow, but there is something else. And we call this the baby seal type of sphenoid sinus, a clear cella, and that is rather frequent. The bony septum is not in the midline, but is attaching to the carotid artery. So this is essential. The septae in the sphenoid sinus are not midline, they are multiple. They can be double, they can be triple, they can be vertical, they can be horizontal. And that's the thing that you have to study them. One of the reasons that we prefer to have nice CT scans, but it's not always possible to get it in all cases. If you have that, study that anatomy. A lot of these, like here, the septum is attaching to the carotid artery. You want to know that, because if you enter here, you think this is the sphenoid sinus, but there is more to it. So then you would miss the midline. And the same here, you see an Onodi cell in the upper part. If you would enter there, you have no clue where you are. But you have to realize that if you enter lower, this is not the whole sphenoid sinus. There is a horizontal septum still. So studying all these different, because there is no standard, but I have to tell you, these bony structures are your absolute anatomical guidance. If you know where they are, then it is easy to orient yourself when you are performing the surgery. We always say that in MRI scans, we can't see them. This is a macroadenoma. You see the pituitary gland on the left side. But then you have to play with the window on your screen, because then it is easy to see. Just on the MRI scan, they are all also there, but not on the standard setting. So play a little bit with the images. The same here. It's on the regular T1, it is difficult. If you enhance the whole Hounsfield units, then you will see the septum, which is so important, because you otherwise have no clue that you have to go through this septum before you are close to the cella.
1 more minute, Andre.
Yeah, I know, and that is, I finished with a short video of this to tell you how to perform this. Very quickly, I don't know. Well, in the Netherlands, we use cottonoid soaked in a solution with cocaine and epinephrine. If it is not possible for you to use that, you have the epinephrine, because this will reduce the swelling. So that's typically, this is already middle turbinate, inferior middle turbinate. These are the two structures you see first. You enter a nose. This is inferior turbinate, the larger one. And if you pass it, you see the middle turbinate. It's not complex. Inferior, middle, very easy. Go between those two. In the very depth, you already see the superior turbinate. Often we have variations, and the so-called spica, that means these lateral extensions, they are frequent, more often actually on the left side, I don't know why, but you usually can go above them, so you don't have to deal with them. And then we remember the ostium is in the lower part of the superior turbinate, the lower third. The superior turbinate is a little bit more whitish, that you can see here. It's whitish and smaller, thin. In that lower 1/3, you will always find the ostium. If it is not there, tap it with your suction tube and you will fall more or less into the sphenoid sinus. You can use any instrument. You could use punches, this so-called the mushroom punch, or it was developed by Stamberger, who is an ENT surgeon from Graz in Austria. You can use a drill, you can use kerosene punches, but you have to enlarge it, and then you have to connect both of them. That already I told you all, so I will move this a little bit more quickly. You see this here. This is the sphenoid sinus with all the structures. So my recommendations is that you have to get used to endoscopes as often as possible. Get used to that instrument and the optics and how to handle it. And also make yourself familiar with this anatomy, because it is not difficult, to be honest. The individual anatomy, because every patient has a different nasal anatomy, especially in the sphenoid sinus, that's no trick. It's in the image. Study it. That's important. And I always tell you, because dealing with the nasal mucosa can cause bleeding, interact with your anesthesiologist. I tell them that the first part of the procedure could be painful on them, so they should give enough, and therefore we use the cocaine because it is also local anesthetic. It's Moffitt's solution. And also the systolic blood pressure shouldn't be not too high. This makes your work as a neurosurgeon a little bit more easy. So in conclusion, I think that certainly I can say you have seen it in the previous few wonderful talks, how established this technique is already, not only for pituitaries, but also for other lesions like craniopharyngiomas. And we have now certainly equal, and I think in the hormonal secreting tumors, even better results than with the microscope. But I have to emphasize, understanding of the anatomy is essential to do that. Maybe a nice job with the tumor, but if you tamper with the nasal functional anatomy, you decrease the quality of life of your patients, and you don't want to do that. So thank you all very much for your attention, and I'm looking forward to the next talks and next lectures, and if there are any questions, I'm happy to answer.
Thank you, Andre. Andre, that was a beautiful talk. You began by saying it's going to be useful for the juniors, but it is useful for everyone. I think learning about this anatomy can never be boring. And each time you hear the anatomy, it is more beneficial for each and every one of us. And I'm going to ask some of the panelists to ask some questions, but just one before that, one comment about, you mentioned about this cycle between the turbinate, they swell and then they they go down after. It's quite interesting because I think people who does breathing exercises in yoga, they often will realize that is,
Absolutely, absolutely. The people doing that, they realize. We in normal life, we don't realize that very well.
No.
You only realize it during flights. And now we are not flying anymore. We are not. But then it dries out and you feel uncomfortable because this tampers with the normal function and also the rhythm of when they turbinate swell, they recuperate. So then the mucus, the goblet cells do that. The turbinates are so-called cavernous structures. They can swell and they can decrease. They swell and decrease. I mean, if you had a common cold, not COVID, but a cold, then you also know that when it is swollen, it is on both sides, it's not comfortable. But it's about an hourly and sometimes by 2 hours, but it's a rhythm that we more or less only breathe through one nostril. We don't realize that.
Well, thank you. I think Ibrahim's Bey had got a question.
Thank you, Andre, for this very pleasant presentation. As everybody says, it's good for the juniors and for the seniors. A few of the endoscopists mentioned an observation. I'd like to see whether you have the same feeling. They say that whether you have one septum or multi-septi within the sphenoid sinus, one septum would always go to the carotid. Is that true? And what was the incidence of carotid injury in your series?
Well, it's so odd, and personally, I never have seen experience a carotid injury. I always feared that I would. I mean, if you do 40 years of neurosurgery, you have to see a carotid injury. No, but to be honest, indeed, if you have one septum that typically curves and it goes into the attach on the carotid artery on one of the sides. I can tell you that sometimes there is not even bone on the carotid artery. I have seen 3 cases of that. And now I can tell you, because of the experience of one of my best friends, who told me that when it was a denuded carotid artery, and they removed all the bone and the keratin, and that lady, when she went home after 7 days, she experienced a carotid bleeding spontaneously at home and died there. What I always do when the carotid is denuded, also when I go into the cavernous sinus, I never expose that artery to the air. I don't know if that is true, but I always cover that with not only with fat, with gel foam and with the flap or a part of the turbinates. I want that carotid artery really protected. But it's true. I tell my residents, never try to just break the septum away. In the sphenoid sinus, never break anything. Drill it, remove it slowly. Never take a rongeur and just break it off. Because I can show you the video where this happened, because Jeremy, a good friend of mine, showed me how this caused a carotid artery injury. So I have seen this, and I think I have been most probably the luckiest neurosurgeon in the world. All my 1,700 pituitary surgeries never had a carotid artery injury.
Thank you.
I'm just lucky.
Thanks, Andre. I think Igor, you wanted to ask something, Igor?
Yeah. Comment to the question at the same time. I would say some cases of third eye bleeding, such as you described, cases that were sent for us to the endovascular department for repair or occlusion. And discussing with our colleagues, the description was of no injury at all during the procedure. So I have some feelings, some thoughts about it. You know, the carotid artery there is is not made to be exposed.
Yes.
Like you don't have the same, probably the same histology, the same adventitia, the same connective tissue around it as you would have, for example, in the neck. And then when you take everything that is around it, you take the bone out and you live like this, I'm not sure this will be at long term a good idea. And the question is, one of my thoughts is a possible mechanism of the tardive injury will be a thermic lesion due to the drill and you know, high speed rotation of the drill and the thermic lesion of the wall. Because the cases I was asked to treat, you know, some of them were, you know, the bleeding arrived several days after surgery. So what are your feelings about it?
It absolutely, I fully agree with you. That is an interesting thought, because with surgery, we change the natural habitat of the area. You could imagine, you could say, listen, if that carotid artery was never covered by bone, yeah, but it was covered with mucosa. It was with a very tiny little ostium and only had some airflow. We completely changed the whole structures there when we perform surgery. And indeed, the thermal injury is not neglectable. The thing is, I don't like the drills with attached rinsing, because this is much bigger and difficult to bring into the nose. So I have an assistant rinsing myself, but this is thermal. So if I drill the bone around that area, I can say that maybe this is a kind of adventitial damage that will cause a kind of pseudoaneurysm and then rupture later on. Because you are completely right. All those cases that I heard of and have seen, spoken of in the literature, they occurred immediately, but a few days later, or 2, 3, 4 days later. And for my friend, actually 7 days later. And that's odd. I can tell you that I have seen vascular catastrophes caused by myself quite a bit. And
Dr. Andre, I think about the catastrophe and complication,
we
we'll
will
leave
do
it
that on
for
Friday.
with Dr. Keki tomorrow.
Yes.
Okay,
Friday.
because I think
Friday.
we should be proceed. Thank you.
Thanks very much. So we'll move on to the next session. And Andre, while you have time, just that couple of questions on the question and answer sessions, if you could answer that. And Pablo, we ready with Casadi's talk?
Let's try. I'm not sure, but let's try, because he told me he cannot hear us properly. But let's do a check. And if we cannot, we will proceed with the next speaker. Can you hear us, Casadi? No.
We can see the screen. Casadi, are you able to hear us?
No. He can only talk or share a screen. He cannot do both.
Really?
No.
So we then move on.
Yeah.
I couldn't hear you. I couldn't, but I'm trying to. Can you see my screen?
Yes. Yeah. Open your PowerPoint presentation. Let's try one more then.
Okay. I've opened.
Yeah. You can talk
Can
now.
you hear me?
Yeah, we can hear you. Yes.
You can hear me now?
Yes.
Yes.
Okay.
Thank you.
Let
Casadi, we can't hear you now.
I think it's not working.
I think when it's made full screen, it probably is not working. When he was, Sadi?
I could hear the voice and then it goes down. Then I have this funny noise, you know, as if a microphone is open.
I think it's an issue with the audio setting. When you're on full screen slide, then we cannot hear you. I think you can just try without using the full screen mode.
Okay. Let me see. Can you see now?
Yes, you can carry on now, I think, with the screen.
Carry on like this, huh?
Yeah.
Yes.
Okay. Thank you very much. So, no, well, no.
I think we still have an issue, Kasadi.
Okay.
Pablo, I think it's not going to work. Maybe you may want to work with Kasadi to adjust the audio settings and disable some of the automatic settings on the audio setting, and we'll move on to the next talk now.
Yeah.
Is that okay, Kasadi? Sorry.
Problem.
Okay.
It's okay.
No okay, so we come back to you. We'll keep working on it. And I would like to invite Professor Chandrasekhar Pituitary for his talk. And is an internationally known neurosurgeon, lots of massive experience in neurosurgery, especially endoscopic surgery. And I'm very honored to invite Professor Pituitary, who works in Mumbai. And I'm very eager to hear your talk, Professor.
Ramesh, can you ask
Yeah.
Kazadi to unshare the screen, please?
Yeah. Sure.
I can do that. Done.
Thank you.
Yeah. So thanks, Imad, Pablo, and Vladimir for this opportunity. And I'm really honored to follow Anand, who has been responsible in actually starting our program, I should say, to a large extent, and learned a lot of things from him. So you've heard all about the anatomy of the endonasal endoscopic approach. And my job is probably to talk about a few differences in children before I talk about our experience. So basically, if you look at the skull-based surgery and the importance of endonasal skull-based surgery, it's really in last 20 years that there is some literature that has come. There has been very little literature on pediatric skull-based tumors in the last century. And first two papers I could find in English literature from Salt Lake City. And then James Rutka has written a chapter in this book, in the neuro-oncology book. And then there is some experience in 2013 from Liverpool, before we have an explosion now of a lot of references as we go along. And in children, mainly the indications can be CSF leak repairs, developmental anomalies, which are fairly common in Asia, odontoid invagination, another common thing in Asia, and various neoplasms. You get very few, but you still get pituitary tumors, and many of them require surgery because they are functional tumors. Craniopharyngiomas is a common childhood problem, and occasionally chordomas and some other rare tumors. So special considerations in children include small nasal aperture, the local problems of ill-defined turbinates, delayed development of sinuses, a small intercarotid distance, size of the airspace in the nasal cavity depends on child's age, and skull-based growth centers should be minimally disrupted in prepubertal age is the common feeling. So let us look at the development of maxillary sinuses. Maxillary sinuses are usually the first ones to develop, and at birth they are probably filled with fluid. And though it is the largest sinus, it usually reaches adult size by about 18 months. And about 45% show pneumatization about 12 months, but it usually takes 6 to 12 years for them to develop completely. For ethmoid sinuses, again, almost 100% of them are seen in newborn children and are fluid filled, but it takes about 12 years till they get pneumatized. Similarly, the sphenoid sinus, when you look at it, it is one of the later sinuses to develop. And though it is seen radiologically at about 4 months of age, complete pneumatization takes over only after 6 years or so. And frontal sinus is last to develop, takes about 14 to 15 years for it to be completely developed. And this is all beautifully
the audio setting.
Sorry? Am I heard? Hello? Am I being heard?
Yes, we hear you.
Okay. anatomical considerations are very nicely written about in actually laryngoscope with a radiological sort of reference to the anatomy. And what are the important facts are that the pyriform aperture is the likely limit only in the youngest of children below 3 years or so. Sphenoid pneumatization to the planum and sella is usually complete by 10 years. So beyond 10 years, it should not be much of a problem to go for a transsphenoidal approach. And the clival intercarotid distance does not change significantly over a period, over age, and is not prohibitively narrow in any age, unless you have anatomical abnormality like kissing carotids you see even in adults. And the other factors, of course, are blood loss in children, proper set of instruments, which are difficult unless we usually use micro ear instruments for this kind of surgery. And the reconstruction of defect becomes a big problem, especially as we are not sure about feasibility of the vascularized flaps. So first, talk about transsphenoidal surgery for in children has been for pituitary tumors. Edward Laws has written about a lot of experience way back in 1994. And similarly, Delalande has written about it in 1994 as well from Europe. And we have had experience with the endoscopic approach in children. And this is one of our first patients with Cushing's disease, high cortisol levels, high ACTH levels. You can see a microadenoma next to the right cavernous sinus. And in this child, you can see a complete excision has been achieved. You can see the 3-month post-op scan with normalization of ACTH and cortisol levels, and you have a dramatic effect. You can see that the life of this boy has completely changed, and he will grow into a normal adult. Another patient, this is a 12-year-old boy who came again with weight gain and high ACTH and serum cortisol levels. This is one of the rare cases where we had a microadenoma on the left as well as on the right, and both have actually shown basophil staining suggestive of. And I would like to share this video just to show you that the 2-nostril forehand technique is necessary even for a microadenoma. We first used to use this micro rongers to take the bone out of the carotid because on the left side, the tumor is very close to the cavernous sinus wall. Nowadays, we do all this with drill. And I am doing some kind of a sector opening where you can find this tumor on the left side, which is being completely enucleated. And especially because you are working very close to the cavernous sinus, the sella is usually not very much enlarged. It is really a problem of hemostasis. So you need to have suction in one hand and your dissecting tool in another hand. Even if it is another suction, it is okay. So you really need a 4-hand 2-nostril approach even for microadenomas. And I have just for curiosity's sake, because once we found that, we were not sure, but we actually found another adenoma which was more firm, and both of them have stained for ACTH. So this patient had a complete removal. It took about 3 months of cortisol supplements, and thereafter it has not been necessary. And he is actually become a chartered accountant today after about 12 years of his surgery. Prolactinomas grow much larger, and this is one child, and usually they are treated with cabergoline and most of them respond, but this particular child at 13 years had galactorrhea, and we started her on cabergoline. For first 6 months, she responded well. Even her visual chart has improved, but later after about 9 months or so, the cortisol started increasing. You can see worsening of her field defect, increase in the tumor, and you can see that the tumor is going laterally in the cavernous sinuses as well. And this is the CT angio, which we always do whenever we see any involvement of the lateral structures. And here we are going for a approach where we are prepared for a extended approach. So first, the keel of the vomer is being taken off fully. We are identifying the midline clearly, and we also like to take this out fully, because without that you cannot really instrument the anterior cranial fossa or the anterior part of the sella quite well. The tumor removal has started. Part of the sella was already eroded, And you can see that the tumor is vascular. I'm taking out some more bone from the lower part of the sella, which was hidden by the protruding tumor. And now the sellar bone is, sellar dura is being opened further. We usually do a U-shaped opening, but here the sella, the dura was already punctured, so we just enlarge that opening. And then you see with the two suction technique, you are trying to take out the tumor. You have already identified the normal pituitary gland at the bottom, and we are trying to create a plane between that and the tumor on both sides. So usually I would like to dissect the bottom first, go up to the clivus at the bottom, then go on both the cavernous sinus walls, and then go to the top, so that you do not have the diaphragm coming down prematurely and arresting your visualization. So we are removing the tumor from cavernous sinuses. I'm sure you have seen some, and then you use a 30-degree scope and you use a curved suction to take out the tumor from the anterior portion. And you can see that you are almost approaching the floor of the third ventricle now. And this is the tumor coming down. You can start seeing the wall of the third ventricle now. And this is where you will find that the last bit of the tumor is coming down, and you will be able to see both the foramen of Monro very quickly with the choroid plexus. And a near total excision, except for the cavernous sinus component, has been achieved. A multi-center study has recently been published. Last year, there were 2 or 3 papers on pituitary tumors done by endonasal surgery in a spatial issue published last year. And it seems that the results of extended endoscopic surgery are fairly good even for large tumors. And it has become a standard approach now in many centers. I think the other papers have shown the importance of multidisciplinary team and when to intervene, etc. But basically, I think for functioning pituitary tumors, this is of course a good approach. And even for giant tumors, if you have experience with extended approaches, you can get a good clearance of the tumor. Transphenoidal surgery for craniopharyngioma, you have just heard a beautiful talk by Fred. And I would just like to emphasize a few points in children. I think I would not go to the literature. We first started with cystic sellar and so-called infradiaphragmatic tumors, like in this girl, where you can see actually that the diaphragm is elevated, very, very regular. And I would just show you that we have done an extended approach. The superior intercavernous sinus is being cut and the flaps are being reflected. You can see the tumor quite well over there. And then this craniopharyngioma is being removed. You can see that we are getting a good plane between the normal pituitary and the capsule of the tumor. And eventually you get a complete excision of the tumor. And here you can see, rare case, but you can see that the diaphragm is intact and you can see the impression of the pituitary stalk there. This is a postoperative scan which shows no residual tumor. So no follow-up treatment has been given to this child. And about 3 years follow-up, the child has remained well, except for thyroid supplements. Larger tumor, again, you can see that though the tumor is going into the third ventricle, the pituitary is nicely pushed at the back. And again, this is very, very amenable. You make your 2 incisions, one in front and one behind the superior cavernous sinus, then coagulate it in the middle, open it and start removing your tumor, and make sure that at the back of it, your pituitary gland is quite intact and it is not interfered with. And you start removing the tumor gradually. Fortunately, in this patient, all the calcium was at the bottom and the cyst was at the top. So it was much easier to remove this tumor. You have seen some beautiful videos, so I would not take you through. This is about 3 years follow-up scan, and you can see that one of the biggest advantages we find in endonasal approach is the premorbid obesity complication has reduced drastically. And diabetes insipidus also is about only 30% or so in our series. This is one of the patients operated in a workshop with us. This child had, you can see that there is no aerated sphenoid sinus on the CT scan. And in spite of that, with navigation, you can literally drill between the 4 blue lines, as it is called by many endoscopic surgeons. And this tumor could be completely excised. This is again a 1-year follow-up scan. A tumor which is going into the lateral margin, but there was quite a broad stalk. and you can see the vessels were displaced. So we thought we'll give it a chance. And this is being operated again by the similar approach. I would just like to show you that it is possible to show, this is a recurrent case, and it was possible to save the stalk. As you can see, the stalk is seen nicely here. The pituitary is at the bottom, and then we are trying to open the sylvian fissure on the left side. You just have to angle the scope. First, we have taken out the suprasellar tumor, and then you will find that once the suprasellar component of the tumor has come down, we have found a good corridor going to the sylvian fissure. And you can very well see the middle cerebral artery in a moment once that part of the hemostasis is achieved. So after a good irrigation, you can actually see the stalk quite well, and the carotid and the middle cerebral artery on the left hand side could be seen. So if you have a broad enough stalk, you can try this. Otherwise, for lateral extensions, I would not recommend this, especially not children with small nostrils. So basically, the key lessons learned from this are that it can be done. You need to be prepared to have an extended endoscopic approach, and usually above the age of 3 years, it should be possible. Our smallest child whom we operated for craniopharyngioma was 3 years. And if the tumor is very large and has a large cyst, in such patients, what we do is we first do an endoscopic transventricular procedure, drain out the cyst, and a couple of days later, we go for the endonasal approach. And we have found that our CSF leak rate as well as radical excision rate has certainly improved after that. I would not again take you, this is the tumor coming out. Tumor is usually not adherent to the third ventricular wall. It can be adherent to the hypothalamus. And we feel that if we decompress it 2 or 3 days in advance, we can probably reduce that adherence to some extent. And this is the last part of the tumor coming out from within the third ventricle. And you can see the previously inserted reservoir here. And this child is now followed up for about 7 years without any recurrence. Basically, the outcomes following endoscopic endonasal approaches, which have recently been written about, are fairly good in most of the papers. And this is a Korean paper, again, 77 cases of skull-based tumors removed by this, most of them craniopharyngiomas. Our own experience is of 54 cases. In last 11 years or so, we started operating on children with skull-based tumors around 2007 or 8, and 54 patients, about 64 procedures have been done. What is important is in 0 to 4 years, we have 11 patients, and I'll talk about them separately. Almost half of them are craniopharyngiomas, functioning pituitary adenomas, CSF leaks, and there are some congenital anomalies like meningoencephalocele, Rathke's cleft cyst, and bony abnormalities like odontoid invagination. So these are the indications. This is a Rathke's cleft cyst, again operated by a similar approach like a craniopharyngioma, and we wrote about this in recently. This is a patient with suprasellar epidermoid, and we were wondering, both the parents were doctors, they preferred to have endonasal approach. So we went ahead and operated on this child. This is an 8-year-old child. You can again see the extended approach here, and 30-degree scope, and the tumor gradually coming out. You can see the anatomy beautifully, like you see after removal of epidermoids. And in such cases, of course, repair is difficult, and you need to use a nasoseptal flap, and it has not been an issue. We usually actually pack the sella with a little bit of cartilage, and then or bone, and then we do the nasoseptal flap. This is postoperative scan, which you can see that there is some fat, but there is no residual epidermoid. This is a petrous meningioma. This girl came with a 6th nerve palsy. And again, we have been able to take this out completely, and you can see beautiful anterior brainstem here. Recently, James Liu has done this literature review, and he has also found almost 500 patients operated for endoscopic skull-based approaches, and found that it is a acceptable procedure with not a very severe morbidity. As I was telling you, odontoid invagination seems to be a common problem in children in our country, and with distraction procedure, this is becoming much less common now that you need to do transoral or transnasal odontectomy. But whenever there is a high riding odontoid, it becomes much easier to do a transnasal procedure. And this is one such patient where I'll just share with you. We do two kinds of flap. We do a nasoseptal flap, and if we need to come down to C3, we need to do a nasopharyngeal flap, and we stick both of them together, which gives a very robust kind of a. So this is how you drill it, and this is how you go to the odontoid, and then you have exposed the whole dura, and eventually both the flaps will be placed, and this is the postoperative scan, which shows a good excision. I think these kind of procedures are mentioned only probably in the in children, only in the Pittsburgh experience. We have about now 6 or 7 cases. The smallest children we have operated are for sphenoethmoidal encephalocele, and we have done 2 patients by endoscopy alone and 2 patients with combined procedure. And here it can be pretty difficult because it's a fairly large defect, and we have had to use a nasoseptal flap in this patient. The youngest patient where we have done a nasoseptal flap is 11 months, and there is now experience coming up with this kind of procedure from China and from another center in India. And this is another patient with a recurrent CSF leak, which we have treated, and we have used fluorescein here because we could not identify the defect without the fluorescein. So to sum up, I would say that use a pediatric endoscope, use micro-ear surgery instruments if you do not have special instruments apart from your usual pituitary instruments. You should judiciously use for intracranial pathologies after reasonable experience with pituitary surgeries. You may need to use a combined approach in meningoencephaloceles and some craniopharyngiomas. I feel we have published our experience in about 20 cases like that. And I think a good ENT colleague is very, very important. And some of you have probably met or interacted with my colleague who's extremely passionate and dedicated to this. And post-op care, you really need to do quite well, especially they need 2 or 3 sittings of post-operative nasal cleaning, and saline sprays need to be continued for almost 2 months. I think in these days of COVID, we have started using this PAPR to do all endonasal surgeries. And we have written about our experience in these 2 papers recently. And I think hopefully these days will pass and we'll be able to meet physically very soon.
Thank you. Thanks very much, Prof. Pujari. I think we just have to, I can't see any questions on the question and answer session. I have Andre and Ibrahim asking to make some comment, but in the interest of time, we'll just take one question. We'll go for Andre this time, but if you could summarize your question, and then we'll take one question and then move on. Andre?
Okay. Yeah. No, well, this is not a real question because I know your facility very well. I think that especially in the pediatric age group, it is essential to have a good cooperation for extended surgeries with an ENT surgeon. And I was happy that you mentioned that I helped you with starting up the program, but I cannot emphasize enough what I learned from you and also from Nishit Shah, your ENT surgeon, about dealing with the nose in children. It's very special, but you can do a lot, and that was what I really learned in Mumbai. And I saw you and Nishit actually in those. I recognized him, Chandra, in these astronaut suits for the COVID area. But really, I think maybe not for the standard pituitary, but for extended, it's a cooperation. It's a teamwork. And you have to start early on. And I always tell my people, it's like going to dance lessons. You have to learn to dance together. Initially, you step on each other's feet, and it doesn't look very well. But after some time, you can dance in a competition, and you do very well. And I know your cooperation over there. So that team effort is so essential for the success of such difficult cases.
Yeah.
It was amazing, Chandra, what you
Yeah.
have experienced, and I only can congratulate you.
Thanks, Andre. Thank you very much. I will move on. Pablo, we ready with the Casadi?
Yes, we are gonna do last try and
Last attempt.
Perfect. So let me thank John Bennett from Neurosurgical TV. He gave us a good advice. So he's using your phone now.
Can you hear me? Can you hear
Yes.
me?
Yes, yes. Carry on.
Yes.
Fantastic. Okay.
Very good.
Third attempt. Good. I'm going to talk about supraorbital approach to pituitary tumors. Our experience in Harare, in Zimbabwe. First of all, a bit of history to know where we are coming from. Krauss in 19th century first demonstrated the supraorbital subfrontal approach on cadaver. Then 8 years later, he demonstrated and did the resection of skull-base meningioma through this approach. In 1913, Fraser advocated a supraorbital ridge resection, which was found useful in surgery for pituitary adenoma. We can imagine those days, they didn't have the facilities we have now, using microscopes and of course, endoscopy and so on. In 1990, Pevsky and colleagues popularized the keyhole concept on the technique commonly used today. So this what you call the supraorbital keyhole craniotomy. The evolution, however, began with Fedor Krauss. Okay. More recently, Jane and Delachaux, described the supraorbital craniotomy, and we have also other variants described by like people like Al-Mefti and so on. Our experience in Zimbabwe is that until 1994, there was little data about the pituitary tumors in Zimbabwe and in Africa actually, and people didn't believe that it was common. And this is not only special, something only can find only in Africa. But I remember when I was training in Belgium, initially, we didn't have a lot of patients because people didn't believe that this pathology existed until progressively some team started now to work together and then managed now to start now to identify the patients first and then to start now to refer them. For us, there was both, of course, lack of identification of those patients and also an availability of CT scan and also lack of technology, even though we had sometimes some tumors, but didn't have the technology and we didn't have the instruments. Yet we know that 21% of brain tumors were pituitary tumors. Our study was a period, we looked at the patient on a period of 3 years, and there were about 37 on 40 to 42 patients case which were retrieved. And the age of the patients, you can see it on the screen there. There was 22 females and 15 males. 82% of patients were Black. You wonder why I'm saying they are Black when we are in Zimbabwe, because Zimbabwe is actually multi-racial community. So we have to distinguish where the patients are coming from. And referring doctors were mostly general practitioners and ophthalmologists, which is quite interesting because, for example, a gynecologist never send patients until recently when we went to speak to them and then showed them how we were operating. They came to theater so that they believed that it was possible to do this kind of operations. Most of the time, patients had complained of headache, blurred vision, or they felt very, very tired. And specific symptoms, there was decreased libido, galactorrhea, or secondary amenorrhea, or sometimes depression. The average delay for patients to come to the hospital was about 4 years. Okay. And they came to the hospital because of visual impairment in 85% of the cases. Others came much, much later. And because we were treated for other problems, which were not actually real problems. And the commonest hormonal test we did is not very sophisticated. because at that time we didn't have really endocrinologists. Now we can do quite a number of investigations. So could do PRL, cortisol, thyroid hormone. Which type of tumors did you find? Prolactinomas were the majority, then non-secreting, followed by non-secreting tumors, and then some patients with acromegaly. We did investigations, CT scan, that's allowed, of course, to make easy diagnosis in 26 patients over 37. And then we see that the MRI we did in 31 patients over 37, because some of the patients actually who had MRI had also CT scan. The operation, the total debulking was done in 23 patients, and partial debulking was done in 14 patients. I'll come back to that and explain to you why we had that. There was no death, fortunately, and patients improved, the symptoms improved in 83% of patients. It means headaches, blurred vision, secondary amenorrhea, loss of libido. Of course, people were blind, never recovered. We had some morbidity like diabetes insipidus in 7% of patients, but it was transitory, and changed visual acuity in 2% of patients, CSF leak, and hemorrhage in the nostril. And one patient had actually a seizure. Sorry, in 1%, we had patients who had seizures. The recurrence rate within 15 months in patient with initially a macroadenoma with suprasellar extension. That's why we saw after 15 months, they were actually having a recurrence, and it was the rate of 10%. But after 5 years, the recurrence rate actually went to 18%, which meant that definitely the work we were doing wasn't adequate. Or, I mean, we thought we had removed all the tumor. In fact, we didn't remove completely the tumor. In terms of classifications, we use the same classification like anybody else, you know, stage 1, 2, 3, and 4. Now, the ideal goal of an anterior scale-based surgery, skull-based surgery, is to cure patients. It's a curative surgery. And so that you can, by removing completely the tumor. Okay. And also, by doing that, you reduce the brain and nerve retraction. And by doing so, you improve, of course, the visual acuity. Now, we see also that by doing this technique, we prevent, of course, CSF leak. Okay. And these goals must sometimes be modified to avoid causing any harm. Okay. Now, there are different approaches, and we heard prominent colleagues who have developed, they explained about different approaches: pterional approach, bifrontal, transbasal, orbitozygomatic. Then we had about keyhole, and so on and so forth. In my opinion, it's very important to use the technique you can afford. Sometimes even when you know how to do it, if you don't have the appropriate equipment or the appropriate team or the appropriate environment, it's better not to do that the best or the top or the most sort of popular operation, and do maybe the less popular. At least your patient will survive. That's my philosophy. We can discuss about that later on together. Now, of course, when we talk about these supraorbital or subfrontal approach, the first criticism is there's minimally invasive approach. How are you going to remove such a huge tumor through this small opening? And the fear is that possibly there will be only a partial removal of the tumor. So this is what we do when the approach. I'm going to describe a lot of this approach to show, particularly to young neurosurgeons. I think those who have got experience, that evidently it's very easy for them, and they know exactly what to do. And for young neurosurgeons, they should remember that this is where the incision is done. But I extend the incision actually beyond the supraorbital nerve, but I don't cut it. What I do, I avoid this by doing, when I cut the muscles, I go around the nerve like this, and then increase the incision. This gives you a bit of more room. I'm sure that when we start to use endoscopy in this approach, probably we'll reduce the size. But that's not the problem, because after all, it's already minimal and very small. The other thing to be done on the positioning of the patient, the head should be turned on one side about 20 to 25 degrees, and in order to see very well, and therefore, in your view, when you open, you will see quickly the optic nerve, which will guide you towards the tumor. I'll show you nice pictures. The other thing to be done is we need to hyperextend the head. Why? By doing so, when the brain is soft, you can now, when you remove the CSF, this brain will gently fall down to the vertex of the brain and then actually open up the base of the skull. And the view is fantastic. Just basic anatomy. Those are the things you are going to find to know. And in fact, you won't be, it's not a dangerous operation, because in fact, the anatomy, the structures we are going to find, those which are dangerous, are actually far from where you are going. It's here, you can recognize, of course, the structures here, thanks to my friend Hype Cherian, who allowed me to use his slide. And I have a slide from my friend Martinez, and you can see here, which he showed actually yesterday, and you can see all the anatomy. This is the only anatomy you need to know, and those are the structures you need to avoid. Then again, to explain, this positioning again, you can see that here I've summarized everything we've been talking about. The head is turned to the left, and you can see here that there is hyperextension of the head as well, and I'll show you that in theater in the real patient. And the craniotomy is done at this level, and that's where the incision is done. The nerve can be actually spared without any problem. That's basically the summary of what is done. The skin is opened, okay? You can see here that we are removing the periosteal thing, and then we end up by doing those are sort of standard approach. We do the craniotomy, and here you see that the bone has been removed. Here you can see that this is the brain, and you can see here that's the roof of the orbit, and one has to go just down there slowly, gently. You don't have to pull the brain, just leave it coming down slowly, just by absorbing, removing the CSF. This is the patient now in real time. It's a patient in theater. As you can see, the head is in hyper extension. You see the axis is going this way, so that when we release the CSF, the brain will actually fall here on the vertex and leave a space on the anterior fossa. You see here that the head has been turned to the left, so that we can have, in our view, the first thing is actually the optic nerve. You see here, I've drawn the area where you find the supraorbital nerve. It's very important to know that. And here, that's the size actually of the craniotomy. This is the size of the bone flap, which is very, very small, but yet you get a nice view. Here, you see that, you see the dura, which is dense because there is, of course, CSF and so on. And here you open the dura, okay? And you'll see that now we go, you see, because just by releasing some CSF, yes?
We can't see the video.
Oh, you cannot see the video.
We're seeing the actual pictures, but there's no video going on.
No, it's not a video. It's pictures.
It's a static picture.
Static pictures. As I didn't want to show videos because it worked and then it didn't work, and so I didn't want to make it complicated.
Sure. Yeah, that's fine. Carry on then.
Okay, they are just pictures. Okay. You see, for example, here, there was absolutely no retraction just by removing the CSF, and you see that the brain is becoming very soft. And here, without even pulling, we can see here already the tumor down here. But it's not actually pituitary tumor, but it was another tumor. But to show you how the approach is so easy. And look here, for example, you see, it's very good to open the system before you go towards the midline, so that you don't pull on the not the optic nerve, and you get to the midline, and you do a small incision, which is very important, always in the midline, a bit anteriorly, because when you deal with pituitary tumors with suprasellar extension, you'll see that this part, the top part, you don't see it, but you see it, it is hidden behind the brain. So what you need actually is to make a hole and then remove progressively the tumor from that opening. And the tumor actually will come down progressively. And if it doesn't come down, we use Valsalva maneuver. Usually I ask the anesthetist to do what we call positive pressure ventilation. And that actually pushes the tumor to the bottom, and the removal is quite easy. But one has to be very, very patient in order to remove completely the tumor. And when the operation is finished, when you close, it's very cosmetically, very, very good. And usually after 3 months or 6 months, people are having difficulties to recognize where actually the operation was done. So in 35 patients where we did this operation, 12 had meningiomas, 23 had pituitary macroadenoma. So those are the patients we are interested on. So few examples where we had before the operation and after the operation, and also in this case, before the operation and after the operation. In this case, actually, there was a small residual tumors remaining there, but patient did very, very well. This is another case where the tumor was removed without any problem. It's a very, very simple operation. Here, it's not a pituitary adenoma, it's a cellular meningioma, tuberculum cellular meningioma, which was also removed with the same approach and the same technique. I would say that this is a very simple and affordable technique. Doesn't require a lot of technology, but one has to be very meticulous. You have to take your time to remove the tumor. You have to do it step by step. One doesn't have to be in a hurry. There are, of course, many surgical options. We saw from other colleagues, they were showing cases which were actually more complicated and how to do them. I'm not saying this is the solution to all tumors. I'm saying most of the tumors with suprasellar extension, this is the way to go. There are, of course, other possibilities which are not excluded, like endoscopy and so on and so forth. If one has access to that, definitely. But this one is much easier because what you need just microscope and micro instruments, and of course, good diagnostic tools like CT scan and MRI to get really to the tumor and remove it safely. Thank you very much.
Thank you, Kasadi. That's a great talk. And thank you for stopping right on time.
Thank you.
So we will, while I think the next speaker is getting ready, we could take one comment. I think, Takashi, you want to say something, Takashi? No, okay. Well, I'm going to invite Professor Henry Schroeder, if he's still... Henry, you there? Oh, you got two screens.
Yes, sure, I'm listening carefully.
Henry, it's a great honor for me to invite my great friend Henry from Pitfalls University, Professor and Head, and everyone knows him, so I don't want to say anything more. And we're all eagerly waiting to hear your talk.
Yeah, hello, Imad, Vlad, Andre, and all my friends. It's very good to see you. Thanks again for the invitation. I think I will try to save some time because many of the things I wanted to tell you are already said by Andre very nicely and also by Fred. So my topic is craniopharyngiomas, endoscopic endonasal approach, and especially how should we deal with the pituitary stalk. So in general, what is the best approach? There's a lot of controversy still. Transcranial approaches, I have tried all of these. The most severe problem for me was always that you have to dissect through these windows in between the optic nerves, the optocarotid window, retrocarotid. So always is some important structures in front of you. And that's why the endonasal approach is so beautiful for these lesions if they are mostly in the midline. You see here, this is a case where you see the chiasm pushed by the tumor in front. Somebody has a microphone. Ramesh?
Yeah, I mean, I think it's probably coming from you on two screens. So Kasadi may be on two screens. Let's see if we can mute. Pablo, are you able to mute one of the screens which is making the noise?
One of Kasadi's not muted.
I see well, everyone is muted. Now.
Everybody muted now? It's okay now?
No, it's perfect. Thank you.
It's fine.
And now you can hear me, not like last time.
No, yes. We can hear you very well.
Better.
Good. So this is one case what I had when I was a young consultant and I made a pterional approach. But you see, these tumors frequently cause a prefix chiasm. And that's why there's no space between skull base and optic chiasm. And you see the chiasm here. And when I came in, it was a problem. I saw just optic chiasm, carotid artery, and had this small window where I could work through. And this is, of course, not nice because most of the tumor is not visible. So the endonasal has, of course, a big advantage because you come from below and you can look under the optic chiasm. Andre has given a beautiful description of the anatomy, so we can go very fast through this. The main landmark for me is always the choana because this is a fixed landmark. You see the turbinates look sometimes very strange. So this is all middle turbinate. This is not superior, this is all middle. So sometimes it's very difficult, even especially when there was a previous surgery. But the choana is a fixed landmark. Then we identify the superior turbinate. And as Andre said, the turbinates are so important. And I always was taught by my ENT doctor, please don't take them. And so in most craniopharyngiomas, we leave all turbinates inside. And then we have to go between the septum and the superior turbinate, the sphenoethmoid recess, and then we are looking for the ostium. And if you have the ostium, you have a good landmark, and then we harvest the nasoseptal flap. Then we can expose the vomer, and we can resect it. We always use a cutting burr at the anterior wall of the sphenoid sinus, and then we go to the posterior wall. I completely agree with Andre. We take a diamond drill and we try not to fracture. If it's very thin septum, of course, you can also fracture it, but the thicker ones, we take a drill and open the skull base here. And if you have a very well pneumatized sphenoid sinus, I think there's no need for navigation. So we just have our orientation, which is much more precise when we look at the anatomy, and we have the sellar space, we have the clivus, we have the clinoidal carotid, the cavernous carotid, the clival carotid, and all can be seen very well if the sinus is pneumatized. If it's not well pneumatized, we use navigation, of course. And if you have a lateral recess of the sphenoid sinus, which is well pneumatized, you can see V2 and also the video nerve very nicely. So all is depending from the pneumatization. And if you look with a 45-degree endoscope behind the sellar space, you can see the basilar artery, you see the oculomotor nerve, you see the perforators with the thalamus, and you see superior cerebellar arteries. Very frequent, you have a duplication of that. And you see here's a basilar artery coming. If you look upwards in the third ventricle, you see the fornices, foramina of Monroe, coral plexus is the mesenteric media, and this is a coral plexus at the roof of the third ventricle. And if you look behind more, you can see the roof of the third ventricle, the habenular commissure, posterior commissure. This is acervulus cerebri, typical sign of the pineal gland, which is in front of that. And here you see the aqueduct. So it's very important for craniopharyngiomas that you not only use a 0-degree endoscope, but you have to use angle scope with 30 and 45-degree angle of view. And you see that is what you see. You see the chiasm very nicely. You see the carotid, and you see the very important branches of the superior hypophyseal artery. And these branches are very, very variable. Sometimes you have one major branch. Sometimes you have 1, 2, 3, 4. So it's very variable. If you have multiple ones, you may take 1 or 2 of the smaller. But if you take this big one, you have to expect a visual problem, and that's why we should avoid that. Skull base reconstruction is very important in craniopharyngiomas because frequently you enter the third ventricle, you have a high flow leak, and that's why the nasoseptal flap has to be harvested. We always leave the mucosa in the area of the olfactory mucosa at least 1 centimeter to preserve olfaction. And then what we found very useful is that we take the mucosa from the other side to create a reverse flap, which is then used to cover the denuded septum where we took the nasoseptal flap. And always we have to take care that we leave at least 1 centimeter of the mucosa in this area as well to have a good olfaction after the surgery. But this helps very, very much in the revitalization of the nose. So the main question, what we have discussed already, should we aim for gross total resection, yes or no? I think if it's possible without causing hypothalamic damage, we should try that. But if you see the edema here around the tumor, you know most of the time you will not have a good plane, and then it's ill-advised to take the tumor out completely because you will have hypothalamic problems. But stalk sacrifice, should we take the stalk or not? Fred has said that we cannot preserve the stalk with complete resection of the tumor. That means we have to make the decision, stalk sacrifice and have a gross total resection or not. I don't completely agree with that. But the opinions about stalk preservation or sacrifice are very variable in the literature. This is a paper from Theo Schwartz, and he made the observation, even if he preserved the stalk, he had a problem that the function was not good. And about 50% you can preserve the stalk, but it's still not working. So you have only the risk of recurrence because you leave the stalk. And that's why the recommendation of Oldfield was, in my view, it is best to choose complete tumor resection except pituitary replacement therapy. So you have a better chance to have a gross total resection. But you have to sacrifice a stalk. And you know, DI is sometimes difficult to deal even with a medication. So the quality of life is decreased if you take a stalk and cause these problems. And there's a Japanese paper that was very surprising for me because they said they make a very radical resection. They even take the floor of a third ventricle. And about 50% of the patients, they found an improved diabetes insipidus. So in my experience, if I take the stalk, all my patients remained with DI. So no one improved when I took the stalk. People say if you have a sharp cut and you're pulling not on the stalk, it can be prevented. But in my experience, if I have stalk sacrifice, all patients are permanent DI patients. So how should we deal with the stalk? There's a classification from the Kassam group. They divided the tumors in pre-infundibular, transinfundibular, and retroinfundibular, depending on the location of the tumor in relation to the stalk. The first type is pre-infundibular. These are the tumors, in my opinion, where you have the best chance to get the gross total resection with preservation of the stalk. So when you open the dura, you see only tumor, you don't know where is the stalk. And on the MRI, frequently you cannot say. One example, this was my first case of endonasal craniopharyngioma resection. He presented with poor visual findings, tunnel view, and you see this lesion. And you see again, this is the chiasm here in front. So if you come transcranial, you have the problem to visualize the tumor. So that time we come here, there is a distance of about 4 or 5 millimeters between the gland and the chiasm. So you go in, you see this is the pituitary gland, this optic nerve left, right, and this is the arachnoid which is open first, and you see the tumor. No stalk is visible. First is debulking of the tumor with the CUSA, and then we dissect. And you see, because of the HD camera quality, you have such a good differentiation between the tumor and the tissue. And here on the left side, I found the stalk and I could find a good plane. This is not tumor capsule. This is a paper-thin hypothalamus, which can be dissected carefully from the tumor, and the last adhesions are then cut with scissors. So we have a very good optical quality. We can see all the small perforating arteries, and we can remove the tumor because we have such a beautiful plane to dissect. And if you look inside, you see this is small third ventriculostomy created by the tumor. When we look inside, you see here the metha intermedia. But you see all the small branches of the superior hypophyseal artery, and you see there are multiple branches are preserved. And this is the stalk pushed to the right side, and it was not very adherent to the tumor. There was a good dissection plane. And you see after 14 days, improvement of the visual field, almost normalized. And he's now 10 years after surgery and no recurrence. So I don't agree with Fred that it's not possible to have a gross total resection with preservation. But I agree that in many patients, it is not possible. And you see no DI, no obesity after resection. And he is just needing a replacement of thyroxine and testosterone. Otherwise, he's doing well, no DI. The second type is the transinfundibular, or what I think a better term would be intrainfundibular craniopharyngioma, which is arising in the stalk. And if you see that, then you know preservation of the stalk with function, it's impossible. So what we do in these cases, if the stalk is very well working, is we open it here. And if you look inside, you see it's all is cystic craniopharyngioma. And if you try to resect it, you destroy all the hypothalamus. If you look from outside, this here is all hypothalamus. This is the floor of a third ventricle. It's not tumor. So if you take that out completely, then of course you will have a complete hypopit patient. So as one example, this is a 29-year-old male. He presented with headache, fatigue, and decrease in performance. And he was brought from his unhappy girlfriend to the doctor and said he is not well in shape, and they make a testing and they found a partial pituitary insufficiency. They made an MRI and you see a lesion filling the third ventricle, causing a little bit of hydrocephalus. These are the fornices pushed up by the tumor. And if you look to the sagittal view, you see the whole third ventricle is filled with a lesion. And then of course we discuss what is the best approach. Many people said that is the best approach, transcallosal, but you can imagine how fast, how much of the corpus callosum you have to divide to reach this tumor to this area. And then if you look carefully, you see again, this is a chiasm. There's again a prefix chiasm, you see it here, chiasm. But the distance between the chiasm and the gland, which is pushed downward, is very wide. It's almost a centimeter. That's why in this case we said endonasal would be good. Another argument is that the approach should be in the longitudinal axis of the lesion, and the longitudinal axis is this axis, so exactly where you come via the endonasal approach. So we go in, we have opened the cellar floor, we took the tuberculum and a little bit of the planum. This is the optic canal left side, right side is a carotid. And this is the superior intercavernous sinus. So we make an incision of the tumor above and below the superior intercavernous sinus. And then we coagulate the sinus with a bipolar coagulation, and then we can cut it. And then we also cut the whole diaphragma celli, and this guides you exactly to the stalk. So we always see the stalk very early in the surgery, which is another big advantage compared to a transcranial approach. You see, this is a gland. Here's a gland, and here's the optic nerve, and this is all the tumor covered by arachnoid. So we open the arachnoid, and then you see the vessels of the superior hypophyseal artery. And we try to preserve all branches which supply the chiasm. So we open it and we come to the tumor. Then we take some specimens for histology. And this is no tumor capsule. This is all infundibulum and stalk. So we take more specimens, and then we had the ultrasonic aspirator, which is easily fitting through the nose, and we can debulk the tumor. And then again, we found the plane between the tumor and the stalk and the hypothalamus. And you see, we need now a 45-degree endoscope because the tumor is not coming down. And then with a bimanual dissection, we made the decision to dissect because this looks like a gliotic plane around the tumor, but you should not pull. If you simply pull, you stretch the hypothalamus. So it's a traction, counter-traction technique under view of a 45-degree endoscope. It's very important that you do not pull simply. And you see here, my forceps not reaching that, so I had to bend my suction more. And then with the suction, I could go around and dissect the upper part of the third ventricle from the tumor. So you have to dissect the tumor around, and only after you have a complete release from the wall of the third ventricle, then you can take the tumor out. Small residual here. It's a 45-degree endoscope, and now we can look to the roof of the third ventricle. You see here the floor, and you see the foramina Monroe. So from an endoscopic impression, it was a gross total resection, which was confirmed by the MR imaging. The flap healed very well. And this is 52 months after surgery, no recurrence. And he's complete pan-hypopit, although I preserved anatomically the stalk, which was, of course, stretched in all directions, but I could not prevent pan-hypopit. But for me, it was very important that he did not gain weight. I was a little bit concerned that he will get weight, but you see, he's the same weight as before the surgery, and his girlfriend is happy after testosterone substitution. And that's 2 years later, no gain of weight. But we have also other cases. You see this old lady, she has this cystic lesion, she came with a visual field deficit, but she was gynecological completely intact, 76-year-old. So we went in, we saw the cystic lesion, we open it, there's a chiasm, we decompress the chiasm, then we look to the stalk. And said, if I take this tumor out, I think the stalk is destroyed and this old lady will have DI. So we stopped there. The pre-op MRI, you see the post-op MRI shows the decompression of the optic chiasm. And then we sent her, without waiting for recurrence, for a fractionated stereotactic radiotherapy. We always use 30 fractions with 1.8 gray. So that means together 54 grays. And she's now almost 3 years after surgery. And you see no tumor recurrence. And she is so far without any hormonal replacement therapy. So in my opinion, if I have a patient with a functioning stalk, I try to preserve the function. And there's some indication in the literature. Fred has also shown this paper, 95-degree after 5 years, 92 after 10 years, and 88% local control even after 20 years. And I have seen never in my experience a craniopharyngioma which got radiation in my institution with a recurrence so far. So I think subtotal resection for preservation of the stalk with radiotherapy is an option, although we know that after some years, they may develop antelobe insufficiency, but they never develop DI. The third type is a retroinfundibular craniopharyngioma. That means you see the stalk first and behind is a tumor. These are more difficult to dissect. One example, this is a 48-year-old male, progressive visual loss on the right eye. And we see this lesion here. So we open. This is a chiasm. You see the stalk is in front of the lesion, but we had good access on the right side. So we tried to get a good resection of the tumor, but you see again, it's a bimanual dissection. Here we preserve a major branch of the superior hypophyseal artery to have a good vascular supply for the chiasm. And then with bimanual technique, traction, counter traction, we dissect the tumor from the floor of the third ventricle. Some tumors coming out. And then we have still this capsule. And again, we use traction, counter traction, a sharp dissection to get the tumor out. It's very important, I think, that we use the bimanual technique as we used it on the microscope. You see the stalk is well preserved and the gland as well. And you see after 1 week normalization of the visual field, and he's now 30 months after surgery. Of course, it's much too early to say whether he will get recurrence or not. He had initially problems with the eye for some weeks, but it resolved completely and he did not gain weight. So he has the same weight like before the surgery. And he has a partial insufficiency of the adenocorticotrophic axis and the thyrotropic axis, but no DI anymore. And the last type is the intraradicular craniopharyngioma. Usually it was said that it's a contraindication to make an endonasal approach for purely intraventricular tumors, but I think it's not correct because this patient came with an Addison crisis and was panhypopit. And you see this partially cystic, partially solid lesion, and he has severe edema and he has completely confusion. When he came, he was completely confused. And usually I thought I will not get this tumor out because there might be infiltration of the hypothalamus. So again, we look to the MRI, you see this is a chiasm, this is a stalk, this is a tumor, purely interventricular, but there's a lot of space between the chiasm and the gland. So we made the decision to make an endoscopic endonasal approach, and you see the stalk is almost completely destroyed by the tumor, only some fibers remaining here. This explains that he has an Addison crisis. So we take an ultrasonic aspirator to take the solid part. The interventricular cystic part was not adherent, came out very easily. And then we dissect the solid part, but you see there is a gliotic plane. It's not the white hypothalamus. What we see here is a gliotic plane, but here at the chiasm, it was very sticky, and I did not want to destroy this vessel for the supply of the chiasm. So we dissected again by manual dissection. Initially, I tried to preserve the last fibers of the pituitary stalk, but then finally there was almost nothing remaining. And I had to sacrifice the stalk in the end. But there was a good plane, what I did not expect from the MRI. With this edema, I thought I cannot find the plane for dissection. This is a remnant of the stalk, so of course we just cut it, and then we cut the peripheral part of the stalk here to get a gross total resection. So to the there was sticky, the tumor was sticky to the chiasm, but I thought I have a gross total resection, and this was confirmed by the MRI. You see, after 3 months, there's no residual. This is our fat, what we brought in. This is a flap. The edema is completely resolved, and he was doing fine. It took more than 10 days. And that time he was very confused. After 12 months, you see, chiasm looks very good. No recurrence, gross total resection. No gain of weight, vision was okay. And then after 3 years, he developed this recurrence. And then we sent him again for the radiation, 54 grays, fractionated stereotactic radiotherapy. And you see the tumor is completely gone. You don't see any residual. So radiation is very effective in craniopharyngiomas. And of course,
Henry, almost.
Yes, you get complete replacement of the hormones. This is our series of 17 endonasal cases, gross total resection in 9 cases, and in 6 we could preserve the stalk. And when you compare to the transcranial series, at that time we had the policy to stalk sacrifice, so we took it in all cases. What was a problem? CSF leakage was a problem, especially in the case with hydrocephalus. We had visual deterioration on one eye in one patient, but not very much, just 10%. It was worse compared to the pre-op value, and we had 2 cases with obesity. and 2 patients needed a shunt because the CSF leak did not stop. In both cases presented with hydrocephalus. And although we had gross total resection in 10, we had 2 recurrences, and a near total resection, 1 recurrence. So my philosophy is, if the patient presents with pituitary insufficiency and DI, we sacrifice the stalk because anyhow it will not work. If the patient is endocrinologically intact and the tumor can be dissected with preservation of the stalk, I also make a gross total resection. This is mainly in the pre-infundibular type of tumors possible. But if the tumor resection would be result in destruction of the stalk and the patient was good before, and he has good endocrinological function before, I usually do a subtotal resection and add this fractionated stereotactic radiotherapy. So my conclusion is gross total resection is the best option if feasible, and if endocrinological function can be preserved. Radiation after partial resection or recurrence is of course a very good option, very effective. And the endonasal approach is the best approach in most of the craniopharyngiomas, what we see here, not in India where you have the whole temporal fossa is filled with tumor in the anterior fossa, then of course it's not. But if it's a midline lesion, I think it's the best approach. Thank you for your attention.
Thank you, Henry. That's, I mean, as ever, it's a beautiful talk, and the quality of the video is excellent, and the technique as well. I can't see any questions here, and while waiting for the next speaker to set up, do you use lumbar drain or not? Because I heard Fred saying he wouldn't use lumbar drain. Would you use lumbar drain?
I use lumbar drain if the third ventricle is open.
Okay.
Then I would use it.
Okay.
Otherwise not.
Sure.
So our technique for, is my screen still visible? Yes, huh?
Yes, I think you can stop sharing now.
Yes.
I think Ibrahim, you want to ask one question, and we'll move on to the next speaker.
Well, I just want to thank you, Henry, and I want also to thank Chandra for showing these cases where you do radical excision, because you are there and you see a good plane of cleavage and you pursue radical excision. I'm very much against the premeditated decision before surgery that one should go for partial excision and send for radiotherapy, because we are sending the wrong message for all the young neurosurgeons to go there, take a puncture of the cyst, put to Meyer reservoir, and send patients for radiotherapy. Remember that the majority of these patients are young children where the cognitive function will be affected. So thank you. You made my day by showing that radical excision is possible. Lots of neurosurgeons have shown this. Lots of literature says this. And definitely the recurrence after radical excision is much, much less than when you do partial resection. As to the point of the stroke preservation or sacrifice, totally agree with you. If it is affected, you take it out. I have a large series of 106 cases. 56 of them are children. And if the stroke is affected, I don't hesitate a minute of taking the stroke out, because this would cause recurrence, radiation, radiosurgery, Meyer reservoir, and the misery of it all. So thank you for pointing this. And one last point about the obesity. In my series, 106 cases, when the obesity is there, preoperative, usually it persists. But if the obesity comes after radical excision, and I've seen it a lot in children, I've never seen it in adults. In children, obesity post-operative disappear within 2 years. So there's no fear of doing radical excision, and to keep pressing in the minds of young generation that partial excision and radiotherapy is best than radical excision is absolutely wrong. Thank you again.
I think this is not completely true. I think we have in Germany, we have a pediatric guy, and he's following all the patients. You know, when the neurosurgeon is reporting results, all is good. But they are pediatric doctors. They take care of the patient, and they have made a big evaluation of hundreds of cases. And they found that many of the kids have obesity, and this persists. It not goes away.
Persists, exactly, it persists. Ramesh, we should not have a discussion on craniopharyngioma in this extent. Only wanted to add to Ibrahim that there is a difference between just puncturing the cyst and doing a near total removal. And it comes to the point of really wanting to sacrifice the stalk in younger patients, children and younger adults, yes or no? And I think that the literature in adding, we don't know what the radiotherapy does indeed in that, but as Fred already said, even in what we call a surgeon's total resection, even with sacrifice of the stalk, I have seen recurrences.
Of course.
And I have seen recurrences. I remember one case that I was very proud of because it went so beautifully in a case that came in so badly already in the early 90s. He had a recurrence after 27 years.
Sure.
And I had to deal with it again. Still, I think this craniopharyngioma is a tough disease, and I am not like you. I'm hesitating taking the stalk in all cases if it is if there is no hypopituitarism pre-op. I'm hesitant. I'm fully agree with Henry. I have a series of my own patients, children who are obese until now, until the present day. It doesn't go away after 2 years. I'm very sorry.
All right. Okay.
Ramesh, we go ahead. I think there would be an endless discussion.
Yes, I agree. Imad, do you want to
be a whole
I
congress on craniopharyngioma?
Yeah, Imad, you can.
I just want to re-emphasize during this session, nobody from all the speakers recommended partial resection. All of them, they said gross or near total. And I think we all agree on this one. Even Fred did not mention about, but we are defending something was not mentioned. Partial resection, nobody mentioned about partial resection, complete or near total. The issue of stalk is a judgment call, and I think that's what it is. But nobody recommended for all the attendees, they should know what Ibrahim said, and Fred said, and Andre and Henry, all of us agree near total or gross total resection, because the best one who was a master of craniopharyngioma resection was Professor Kazi Yazarjil. He used to say, I remove it completely, but in the later years, when he moved to Pediatric, he said, just wait and for your recurrence. You might get recurrence after 20 years on craniopharyngioma, especially in the younger children. Okay, so there is no mechanism, but everybody agree subtotal or near total resection and no partial resection.
All
just
right,
to make clear for everybody.
Ek, you want to mention something, Ek?
If you stay
if you go and check across the literature, and I think I gave this in my first talk in the series, no matter how you approach this, and no matter how good the post-surgical images look, all series, endoscopic, transnasal, open, retro, whatever, show a 1/3 recurrence rate at 3 years, which is surprising. They almost always show up at the same time, which makes the researchers think that we potentially stimulate growth in stem cells from doing surgery and getting a post-surgical inflammatory reaction. But as you said, Andre, there may be some cases where the recurrence shows up a decade later, 20 years later. So big game, big aim is always gross total resection, but not at the price of maximum morbidity. So near total resection is the treatment of choice if risk is too high. And I'm going to talk about this.
All right.
Well, you are on the next thing.
Sure.
And if you stay long enough in neurosurgery, you will see your own recurrences.
100%.
For sure.
I think we should get Ek talk about his experience.
Okay.
And those that
because we need to finish that craniopharyngioma recurrence.
Sure.
Ek, you want to start sharing the screen? It's a great honor, and it's good to invite Ek Kasper, great friend, and it's a professor and head at the McMaster University. And Ek, you can share the screen now.
I think I am there. Give me 1 second. Do you see my screen?
Yes, you can use your PowerPoint. You can see the Zoom, but
can I make it large?
Yeah,
from the beginning. Okay. So thank you very much for having me and letting me contribute to yet another seminar with a talk on craniopharyngiomas. It's very hard to follow exquisite talks by Fred and especially Henry, and I really want to compliment both of them for what they have shown, and especially Henry is progressively pushing me to become an endoscopic surgeon. But for the purpose of today's talk, I want to complement his talk by trying to argue the other way, why open surgery remains an important tool for this particular disease. And I apologize for some redundancy and some repeat topics and slides that you will see, but it will hopefully help with completeness to cover this topic. Nothing to disclose. So we've heard some excellent talks today about craniopharyngiomas, and we learned many options. However, for more than 80 years, the question really remained, what is the right approach to deal with this? And I think especially when you're not yet the specialist as Henry is with endoscopy, the big question is, how do I personally learn this? How do I learn open surgery for this? Is it microscopic? Should it be endoscopic? Should it be minimal invasive? Should it be aggressive or should it be conservative? Because most of this comes from experience. And if you all remember, the incidence of this disease is rare. It's about 1 in a million, which makes 400 cases per year in the United States. Most of us see about 5 per year in our centers. So even a good person in a good center sees a very limited number of cases to learn this. And in endoscopic cases, you need a certain amount of experience to be as skillful as Henry is, whereas most of us in residency have maybe seen 1,000 craniotomies. So it's not a bad thing to think about a craniotomy as a good tool at the beginning as you acquire your endoscopic skills through pituitary surgery, for example. So what made us think about craniopharyngioma to begin with? Just to repeat, most cases show a supra and paracellular tumor with solid and cystic components, and CAT scans show often calcifications, more so in children's, and patients clinically often present with endocrine dysfunctions, which we have talked about. Classic clinical issues were visual and neurological and cognitive compromise as a triad in conjunction with medical morbidity. This is just a slide for completeness. The patient really comes to you once you have the first scan and wants to know 2 things. The patient wants to know, what are my treatment options? And for the purpose of this talk, I want to talk about surgical resection strategies, and then briefly about biopsy and cyst aspiration and stereotactic intracystic delivery of active substances. The second thing they're asking is, what is my risk of surgery? And you are the specialist as a physician, so you know it much better than the patient, but you can tell them the usual top 10, infection, bleeding, wound healing difficulties, stroke, coma, death, and so on. But in reality, they don't really know how much is much. It very much depends on your approach, on your experience. So a lot of it is iatrogenic, and the second part is hormonal. So don't make decisions based on your initial CAT scan when you see the patient in the ER and tell them you need surgery and I'm going to take this out. There are way too many options to approach a lesion like this, which is like a 4 centimeter partially cystic, partially solid lesion, which could be a number of things, but get really several pre-surgical scans. The risk is not insignificant because resection is difficult. And it's difficult both because of anatomy, and this tumor is buried deep inside the brain, and it's like catching a bird out of a bird cage without opening that bird cage. And it's also difficult because of the pathology. These tumors are very variable. They can be very sticky. They can be viscous. They're often infiltrative, and they're often calcified, all of which complicates your surgery. There are 2 schools of thought we've heard about, either gross total resection for all patients, and that decreases your chance of recurrence, but that still is 1/3, or subtotal resection with cyst decompression. And I think we should all aim for gross total resection, but it isn't a disaster if resection is subtotal, because I think that question has been largely answered. There are excellent reviews from the UCSF group showing that superiority of conservative resection, near total resection, and adjuvant radiation therapy in craniopharyngioma, because for all these cases that were described in the literature, progression-free survival is insignificantly inferior in subtotal resection, followed by adjuvant radiation. and overall survival is only minimally better, but insignificantly better in gross total resections. The big difference is that the postoperative endocrine status is significantly better in patients that did not have that last piece of tumor removed to achieve a gross total resection. So if there's a tiny piece of tumor left, subtotal resection followed by adjuvant radiation had less morbidity. The question was finally, how and when should we radiate? That question is also currently answered. Current treatment of choice is 3D conformal IMRT, stereotactic small field radiation, 56 gray and 28 fractions delivered through 6 portals, gives you a good coverage and control rate of about 90% at 10 years. When should we do that radiation? The answer in adults is likely at salvage, so you don't win by radiating immediately post-op, wait until post-surgical changes settle and the tumor recurs at 3 years or later, and then you get good difference of side effects through your waiting period and good tumor control. So again, to today's talk, how should we pick the right surgical approach when we start our practice? So after coming out of surgery, residency, going into fellowship or after fellowship, you know, you need to learn your anatomy, and then it's because of you and your experience. So how did I learn this? Well, first you need to think about the anatomy. It's all about the sella, and obviously there are open and endonasal approaches available. We need to remember the paracellular region is a very delicate area. It's adjacent to the optic pathways. We said the pituitary, hypothalamus, the vessels at the skull base, and the mammillary bodies. And this has a huge influence on your comorbidity or morbidity to begin with. Vision, hormones, mental status, sleep-wake cycles, obesity, we talked about this. The paracellular region is really a delicate area, and you need to study, even I still need to study before each case, cisterns, nerves, and vessels. And I think one needs to rethink, you know, where does this tumor sit and how do I get there best, as Henry said? Where is my best window? In addition, I always want to look at the blood supply. Although in craniopharyngiomas, this seems to be poorly understood. Most solid tumor parts are supplied via the pituitary and hypothalamic vessels, and the cystic part shows rather little vessels. A few cases in the literature show it can grow into the wall of the lateral ventricle and parasitize it, but that remains under debate. Caveat is, watch your perforators and chiasmal vessels. You cannot sacrifice vessels that are shared between eloquent structures. So the first thing is, when you study your pre-surgical scans, look at the infundibulum and chiasm, and I can tell you from experience, it's very hard to see the infundibulum, so start with the chiasm. Most people have a normal chiasm, which means the chiasm is located directly above the optic and the pituitary. 15% have what's called a prefixed chiasm, that the chiasm is anterior, short optic nerves, which makes your access very difficult. And 15% have the opposite. The chiasm is posterior to the pituitary with long optic nerves, which is nice for surgery. Remember what this means for our surgical approach. A normal chiasm and a prominent bony sella, either anterior clinoids and tuberculum or posterior, will limit your access to the suprasellar and sellar area. So when I look at this first, I define tumor into pre-infundibular, transinfundibular, and retroinfundibular. And as Henry has mentioned, the problem is the pituitary stalk. You can't always see it on the images. And even Yashagil's series of 160s, he said he could only identify at surgery the stalk in about half of these cases and only preserve it in about 1/3, which means really experienced hands have difficulties with this tool. So realize this is a challenge. Translating into 70% of patients usually need some form of hormonal substitution after surgery. There are multiple classifications that are in use. An early one here by Maurice Chou divided tumors in pediatric patients into sellar, infundibular, intraventricular, and global tumors. Later, Yashagil went and divided this more by growth pattern into tumors growing anteriorly, superiorly, posteriorly, or inferiorly. And then you can have multiple subdivisions depending on how this grows laterally. But this is too complicated for me, and I was very happy to see that Henry picked the same classification I did. I like the one that was brought up by Kassam that divides it into type 1 pre-infundibular, type 2 supra-infundibular or in the stalk, type 3 posterior infundibular, and type 4 is purely in the ventricle. So I think approaches should be chosen based on tumor features with particular attention to the chiasm and the stalk. So when you look at the tumor configuration, pay attention to shape and size and location of the solid tumor portion as much as size and location of the cysts. I think the cysts can provide you with working space. Look at areas of calcifications. Look at distortion of normal anatomy, where it could be your first problem you encounter. Whereas potential invasion of the third ventricle visible on T2 or flares on the pre-surgical MRI scan, which part of the tumor reaches the surface and where is it best accessible through cisterns, and is there associated hydrocephalus? The second component is really your experience and your familiarity with an approach. There are often several equally suitable approaches possible to the same tumor. There's no shame in picking one, just pick the one that you are good at. And obviously it depends on your center as well. Do you have intraoperative imaging available or not? Some people swear on it, some people use DTIs, but basic CT MRI imaging usually works well. And then patient parameters. So study the details, get high resolution MRI scan, CAT scans with CTA, and if you can or want DTI to delineate the optic nerves. And I want to show you this example, which is the same tumor from the beginning. So this shows a largely cystic but partially solid lesion. The cystic portion fills the third ventricle. The solid portion really sits retrochiasmatic, so it's a craniopharyngioma type 2 and 4 mixed. And that made me go after this in an open fashion when I learned this. So this is the time to consent the patient. You have good imaging. The question is for what? So first surgical option is, and I want to note this briefly, is there need for shunting? Because quite a number of patients, older and children, present with hydrocephalus. And I think if signs and symptoms are acutely related to hydrocephalus, an EVD or a shunt is suitable. EVD if you want to operate in the next few days, shunt if you want to delay it somewhat or you have to. But remember, bilateral drainage may be necessary if the ventricle is entrapped. Bring the shunts on both sides together into the same shunt valve, so not one ventricle drains faster than the other. They should drain against the same resistance. And if they don't, the problem can be that the overdraining ventricle causes midline shift, and you get actually herniation to midline structure. The second problem described by Yajigal nicely was people can get acutely worse after shunting. That happens in a few cases where you basically decompress the hydrocephalus, and now the tumor with the cyst is pushing against less resistance. So kinking of the optic apparatus can cause a sudden decrease in visual field and function. But you also have to rule out that you're overdraining and you may develop some subdurals. So rescan the patient early, you may accelerate your intervention. And now let's come to the surgical options. Obviously, there are many surgical craniotomy options at hand. That tells you nobody has the holy grail here, knows the answer. And in some cases, when the tumor is extensive and not just in the midline, you may actually need more than one approach in more than one sitting. So there's no shame in saying, I may not be able to take this out in a single session. It is diligent planning what's required here. So modern choices are individualized by patients, by surgeon. I recommend all beginners to learn and read the chapter in Apuzo's fantastic book on brain surgery and complication avoidance. We've heard the transsphenoidal side from Henry and Fred Gentili very well, and I want to talk a little bit more about open approaches. Reiterate, transsphenoidal surgery and management is great, and it's a good way to learn this. For type 1 lesions, intracellular, largely defined to the subventricular, third ventricle space, transnasal surgery and resection is the method of choice and can show, as in this case, you preserve the optic nerve and the pituitary stalk really well. Now, most modern transsphenoidal endoscopic series have shown that craniopharyngioma surgery is suitable. for endoscopic surgery if they have clear features, mainly median, intracellular, and likely subchiasmatic location for sure, small or to medium, with no real paracellular solid component, and especially if they grow along the stalk. And if you're a specialist, you can deal with tumors reaching posterior, inferior, or into the third ventricle. Now I want to show you, for historic reasons, frontal interhemispheric approaches for open surgery. I have not used this for a craniopharyngioma myself, just because it wasn't necessary, but I think the main indication is there used to be tumors that are purely intraventricular or extending into the lateral ventricle. You can't reach that through a nasal approach. The problem is you come from the top down, and you see this in Jarzagil's drawing on the bottoms. You have very limited visibility for neurovascular structures near the cella, and it's a very long reach. So if the tumor has a solid component at the bottom, it's not smart to come down from the top. If you do come down from the top, you can either go intraforniceal, transcallosal, or you can go transventricular. Your choice. I prefer to go transventricular for lots of tumors in the ventricle, because I don't like to separate the fornices in the middle and pull on them. But you have to be aware during surgery and on pre-surgical imaging about vessels, fornix, and keep your callosotomy to a minimum, less than 2 centimeters for sure. I think whenever you cut a white matter tract, there's a risk of cognitive damage. So if you can avoid it, don't go this way. Other approaches may be more suitable. My go-to approach initially was a right-sided pterional approach. It is preferred for the right-hand surgeon, does not retract on the dominant hemisphere, very short working distances, excellent access to the cisterns, direct approach to the suprasellar area with good viewing angles and good topography. Now, when you do this, you do it 100 times in other cases, you just are very familiar with this. It allows you perfect approach to the circus of Willis. And when you learn aneurysm clipping, you use that a lot. Gives you excellent visibility of both optic nerves. So head position is standard, slightly hyperextended. You can combine it with an anterior clinoidectomy. I always remove the lateral sphenoid wing, and you can do a wide urotomy, which gives you good access. This is how this looks. And you have various approaches that you can use. And I want to show you in this picture, on the left lower corner, number 3 is the main working corridor, is likely the optical carotid triangle, seen in the picture in the middle. You see the tumor is protruding between the optic nerve and the vessels displaced laterally, and you can often nicely dissect the craniopharyngioma out from this angle. And this works really well in children too. There's a beautiful chapter by Michael Scott and Ed Smith in the book by Ed Laws. Now, what would I do for this first patient that I showed to you with this type 2-4 suprainfundibular retrochiasmatic intraventricular craniopharyngioma? So I decided to go in via pterional low anterior approach because I wanted to come in from the right and be behind the chiasm. So I got my pre-surgical imaging. You can see that we have the CTA with little calcifications only, but the tumor is largely midline. And the tumor could be nearly totally removed at index surgery. I did open the lamina terminalis to look at the top and behind the chiasm, and that's where I was actually very lucky. There was clearly a sharing of vessels between the solid tumor component and the back side of the chiasm. So I had to leave a small retrochiasmatic calcified remnant, and we did not have any stroke. The patient did perfectly well post-surgery. You can also see the lowest coronal picture in the lower row shows that you often get, with the right side approach, excellent resection of the left-sided cyst wall on the opposing side of the third ventricle wall. It's more difficult to see the ipsilateral side. This is a similar tumor, but it's off midline and it's more calcified. So also type 2-4, and the tumor shows the solid portion towards the left, so it's easy to come in from the right, use the cyst as your working space. Same approach, and I was able to take this out through a pterional approach from the right with a gross total resection. Now here's a case where I came in from the left, and why did I do so? If you look at the tumor images, you see that the tumor is solid on the right side. It sits rather low and it touches the top of the basilar tip. I couldn't tell either chiasm really well or pituitary stalk. And the patient already had a right-sided shunt placed by one of my colleagues. So I felt this is best approach to the left side. In the lower row, red box, you see we were able to separate out most of the basilar tip nicely, but there's a tiny remnant of the capsule of the tumor where it was draped over the perforators coming off the basilar tip. And I did not feel comfortable sacrificing any of the perforators, and to decrease morbidity, I left this behind, and the patient was 2 years later treated with radiation. Second option is go subfrontal uni or bilateral. This is an approach Dr. Sami prefers. It gives you excellent visualization of the optic nerves, and especially through the lamina terminalis to get inside into the third ventricle with long viewing access. And you see the carotids on both sides very well. You can also combine it with resection of the forks if you want to reach up. And
we've got 2 more minutes.
Yeah, in children, that brings you to a nice wide access to the suprasellar areas. If need be, you can extend it like the middle picture shows temporally, so you get a lateral view, take the orbital roof out, and you have very large access to a complicated tumor area. 2 pearls, get a plain CT scan with scout images to look at the frontal sinus, bring your craniotomy as far as you can to the midline and as low as you can to the orbital roof, which gives you great viewing angles, and then you should be able to sneak in there. This is one of these cases that I did with a subfrontal approach and was able to take this out successfully. This is Yajigil's picture about combining subfrontal with transventricular tumors. I haven't seen that, but please keep that in mind. Finally, I want to show you 2 more slides for minimal invasive approaches. This is a slide of a colleague of mine who came to us with this off midline calcified tumor with a cystic component. He said he absolutely would not want to take days off from his normal life as a physician, and he didn't want to accept any morbidity. So we discussed this at length, and he opted for a biopsy with stereotactic cyst aspiration, which took us 1 hour to do, confirmed craniopharyngioma. We radiated the tumor as an outpatient with fractionated CyberKnife 5 fractions, so the patient didn't miss out any of this, and the patient developed some post-surgical cyst re-enlargement, which we could drain with the catheter implantation. So this patient got away with 2 minimal invasive surgeries of 1 hour each and did excellent in terms of post-surgical control. Last slide. Newer techniques that are available have allowed us to look in complex tumors, especially in children, to also use minimal invasive techniques for intratumoral brachytherapy. On the left side, you see the Freiburg experience summarized by Tripple's paper in New Frontiers. On the right side, you see probably the best series of all by Dr. Yu from the Navy General Hospital in Beijing. Multicystic tumors in children that are largely cystic with no solid component can well be aspirated with stereotactic techniques and then filled with P32 colloid. The radioactive colloid will deliver high-dose beta emission, 200 gray to the cyst wall, and these tumors show equal response rates to gross total resection, with 85% of tumors showing excellent tumor reduction or remnants that do not grow and are stable at 20 years. I've just analyzed his largest series. It's going to be published hopefully within the next 6 months. And I think it is an excellent technique we should be aware of and not be shy of sending patients to referral centers. So what have we learned from all this today? Key to progression-free survival remains to control tumor growth. A gentle conservative surgery should be aimed at gross total, but if it is subtotal, just be aware of diligent follow-up. Pick the surgical approach that you master best based on the anatomy and your skill set. Given equal outcomes, there's no shame in leaving a tiny piece behind to not inflict morbidity, because treatment complications define quality of life. And at this point, 10-year survival is above 90% in most cases. So realize that these patients are your walking business card, and you want to do a good job because they will sing your praise or destroy you in the community. Thank you very much.
Thank you. Thank you, Eric. That's been a fantastic overview of the approaches. And Sever, the conclusion comes down to the quality of life, as you said.
I think so.
Yeah, I mean, we can take one comment from the panelist or question from the panelist, and then move on to the conclusion. Anyone wants to make a comment? Okay, Ibrahim. Sorry, Ibrahim, carry on. I'll ask Bill after that.
Thank you very much indeed, Ikad. Thank you for pointing this, that the aim is a gross total resection. And it is there inside this surgery that you decide whether you can do complete excision, radical excision, partial excision, what have you. But to decide pre-operative that I'm going for a partial excision and send the patient for radiotherapy is wrong. This is my message, that we should not teach the younger generation that radical or nearly radical excision is impossible. I have it in my series. Chandra showed it. Everybody, Henry showed it, that you can do radical excision, not at any cost. Of course, I would stop if I'm going to damage the patient. But to have the notion to the young generation that radical excision is equal to partial excision radiotherapy is wrong. We are sending the wrong message to young generation. Thank you for pointing this out.
Thank you. Bill?
Yes, yeah, I just thought that it was very well discussed, and I've agreed with I think the consensus opinion about how to manage it. I just wanted to add one thing, that those particular tumors that the cranios that arise in the third ventricle, and I use the pituitary stalk to identify those ones. If the pituitary stalk is completely in its native position and pushed down, that's an indication to me that that it's not growing in the suprasellar cistern, it's growing in the ventricle, pushing the floor down. If they're intact, I'll try to use a different approach to come transcranially, either through the lamina or through the ventricles, to try and remove them, to try and preserve the third ventricular floor and the stalk. So that's my only comment. But otherwise, I think it's been beautifully discussed, and I agree with the philosophy of Henry, that you know, the midline tumors, the transnasal approach is the way to approach most of them. Thank you.
Thanks very much. So, Keki, final comment for you. Unmute.
One quick comment. Many years ago, it was suggested that if you want to get rid of the entire craniopharyngioma, which is obviously stuck to the stalk, it may be a good idea to section the stalk rather than stretch the stalk or pull the stalk. Is this being practiced anymore by anybody? I didn't hear anyone talking about cutting the stalk. At one time, it was being doubted.
There was discussion. I think even Henry and Fred and there was a discussion about cutting the stalk if need to, especially for recurrent ones. That Henry, you want to comment on that?
Yeah, if the stalk is working, of course, we should try to preserve it. And you can frequently have the problem that you cannot preserve the stalk without taking the function. And this is an intra-infundibular type of the tumors. Even if you preserve the stalk as a structure, it's frequently not working well. In the pre-infundibular tumors, I think you have a good chance to dissect the stalk away, and you can preserve the function, have a gross total resection.
Thank you. Okay, Tom.
Hello to everyone. I'm sorry I've been in the clinic this afternoon, so I couldn't join you for the whole thing. But I'd like to sort of perhaps bring together what Bill and Henry were kind of showing, and may not be obvious to all the trainees, that it is really a good thing to try to identify whether the craniopharyngioma arises primarily from within the third ventricle or from sort of stalk or underneath the stalk, because as Henry showed very beautifully, some of the branches and superior hypophyseal vessels themselves, when they branch into the stretched hypothalamus, may give an impression that it's arachnoid or something, but actually it is the hypothalamus itself. And so if we persevere from underneath in case of a tumor that arises from within the third ventricle unknowingly and spread the floor too widely, there can be quite a lot of damage of the hypothalamus occurring during the process. Henry, of course, beautifully showed cases where he makes a small hole, the small third ventriculostomy, so to speak, and then works through it. But not everybody may necessarily be aware that a lot of damage can be caused without even taking much of a tumor. So trying to determine whether it is mainly third ventricular, for a lot of people, there may be actually better approach in this case.
Thank you. Thank you, Tom. I think we are reaching the final end of the session. I'm going to ask Prof. Kanan to do the concluding remarks and a message to attendees.
Thanks, Ramesh. I'd like to thank the moderator of this session, speakers, faculties, distinguished guests that they enriched that webinar with their expertise, special to Bill, Fred, Henry, and others, as well as the contribution from people outside the faculty. Dr. Soubey has been very active with his valid comments, and we got the message to everyone. I have two announcements to make, that the evaluation of the course is already posted, so people that like to have a certificate, we appreciate their feedback within 1 week from the receiver, and this where we to guide us to improve our webinars. The other announcement, I'd like to invite everybody for tomorrow's complication webinar. Dr. Keki Turel is with us. I have been
on Friday.
On Friday, sorry, and on Friday, yes, after tomorrow, sorry. And I've been to a couple of them, and I think these are a marvelous teaching endeavors, and we'd like to thank him for keeping that one ongoing. Without further ado, and I'd like to check if Dr. Vladimir is there.
Yes, sir.
Vladimir, please. He is a co-chair, and he can give his own opinion about the session.
Well, the both sessions were excellent because they were very compact, and yesterday we discussed aneurysms, and today we discussed, let's say, cell region. And I believe that it was a great combination of high-tech or top-notch neurosurgery with a very, very good teaching. And despite some repetitions which had to happen, it only highlighted the differences. It only highlighted the teaching value of the course. So I believe that among ourselves, 16 lectures with lecturers from 13 countries, you really selected perfectly, Imad. I believe that we all should thank you for both these days.
Thank you.
Totally agree.
One more thing I'd like to give the extension of appreciation to the team from Japan, Dr. Takashi Oko and Dr. Ji Tang, who produced the translation for the people in China and Japan, so we can reach to them.
Thank you.
And a special thanks to Pablo, who has been dynamic. He has facilitated the lecture presentation, and to Dr. Sanjeeva, who has prepared the form for the evaluation. Thank you very much, and have a good day, all of you.
Thank you very much.
Thank you.
Appreciate it. Thank you.
All the best, guys.
Bye-bye.
It's good seeing you.
Bye-bye.
Bye.
Good night. See you.
Bye.
Bye-bye.
Time.
Sadi.
Well. Hi.
Ramesh.
See you. Bye. Good night.
Night.
Good day. Good night.
Good night. Bye-bye.
ありがとうございました。おやすみなさい、皆さん。
ありがとう。
またよろしくお願いします。
Takashi.
Okay, Pablo, you're going to end this.
I'm waiting for you all. I have to sleep, so I want you to go out of my room. Ramesh, bye-bye.
Ramesh is still surviving. It must be very late in the night, Ramesh.
Buenas noches.
You can't hear you.
Can't hear you, Ramesh.
Okay.
Thursday now. Hey, Ramesh, that was a very nice pickup on the angiogram yesterday. Well done.
Yeah.
Okay, guys, enjoy. Good to see you all. See you soon.
Bye.
In the
Bye.
street.
Bye.
Bye-bye, Igor.
Bye.
Not sleeping.